Hello friends. In rapid revision biochemistry, we will cover last 7-year PY topic with concepts and mnemonics. We start with concept. We are in fat state. Suppose I took food, and when we take food, 60-70% of our diet is carbohydrate. Approximately 60-70% of our diet is carbohydrate. When I took food, blood glucose will increase. Carbohydrate prototype is glucose. So glucose will increase. This increased glucose will go to pancreas and will release insulin. Insulin injection. We remember insulin as insulin injection. You know, a question is asked. Very important factor which release insulin is increased blood glucose. So this insulin is increased now. Now, glucose is present in blood. What are the function of this glucose? Glucose is having multiple function. First function is this glucose is stored as glycogen. Glycogen in muscle. In muscle, approximately 2% of muscle weight is glycogen. This glucose, extra glucose, is stored as glycogen in liver. Approximately 10% of liver weight is glycogen. So one function of glucose is it is stored as glycogen in muscle and liver. A question is asked, percentage wise glycogen is more in liver. But total muscle mass is much more than the mass of liver. That's why total glycogen is more in muscle and percentage wise it is more in liver. So one function is stored as glycogen. Another function of this glucose is HMP shunt. HMP shunt. Another name is pentose phosphate pathway. In HMP shunt we produce NADPH and pentose sugar. Pentose sugar. So glucose, one function is storage. Second function is production of NADPH. NADPH produce no ATP. Yes, NADPH is required for reduction. Wherever you want reduction, NADPH will come and will give hydrogen and will reduce. So NADPH is not concerned with energy production. NADPH is concerned with reduction. And pentose sugar is produced by this HMP pathway. So you can remember very easily that HMP shunt no ATP produced. Why? Because nature said if you want to produce energy, go to glycolysis. Means one more function of glucose is production of energy. Production of energy, glucose will enter having 6 carbon. Glucose is having how many carbon? 6 carbon will enter glycolysis. And 2 molecules of pyruvate will be formed. Pyruvate is having 3 carbon. A 6 carbon glucose is converted to 2 molecules of 3 carbon pyruvate, and this reaction is called glycolysis. This pathway is glycolysis, and net gain of aerobic glycolysis. Aerobic glycolysis net gain 7 ATP. So energy production, glycolysis. If you want to produce NADPH, pentose sugar, HMP shunt. And this glucose is also stored as glycogen. So till now I have discussed 3 functions of this glucose. Now this pyruvate formed by glycolysis will enter mitochondria. Now I am going to mitochondria. Now this pyruvate entered the mitochondria. This 3 carbon pyruvate will be converted to acetyl coenzyme. Acetyl coenzyme by enzyme pyruvate dehydrogenase. This acetyl coenzyme enter TCA cycle, Krebs cycle, TCA cycle to produce 10 ATP. T4 TCA, 10 T4 10 ATP. Energy is produced. So you are producing energy from glucose by glycolysis, by pyruvate dehydrogenase, by TCA cycle, and we know that complete oxidation of glucose produce 32 ATP, net gain 32 ATPs by complete oxidation of glucose. When energy requirement of cell is fulfilled, then TCA cycle will stop. Point it out. TCA cycle will stop when energy requirement is fulfilled. Now this extra acetyl coenzyme is thrown out of mitochondria. Now again we came to cytosol. This acetyl coenzyme in cytosol will produce fatty acid. So fatty acid synthesis. Acetyl coenzyme A in cytosol will produce cholesterol. Cholesterol synthesis means you can say that function of carbohydrate or glucose. Glucose is stored as glycogen in liver and muscle. Glucose undergo HMP shunt and produce NADPH and pentose sugar. Glucose go glycolysis, then pyruvate dehydrogenase TCA cycle for energy production. Extra acetyl coenzyme A in cytosol form fatty acid. Acetyl coenzyme A in cytosol form cholesterol. So extra carbohydrate converted to fat. Carbohydrate can be converted to fat, but fat cannot be converted to carbohydrate. Question is asked. So this fatty acid, extra fatty acid bind with glycerol to produce triacyl glycerol, and it is stored in adipose tissue. Maa ka pyar. Yes. So this is a fate of carbohydrate. All these pathway, whatever I have discussed, all these pathways, all these steps are activated by insulin. This is mnemonic, conceptual mnemonic. Yes, I told you that fat state hormone is insulin. This increased glucose will go to pancreas and will release insulin. What is the function of insulin? Insulin will activate all these pathways mentioned on this page, except TCA cycle. Yes, all pathway on this page are activated by insulin except TCA cycle. TCA cycle has no hormonal control. It is regulated allosterically. Means if cell require energy, TCA will go. And if cell have sufficient energy, then TCA will stop. So this TCA cycle is not regulated by hormone. All other are activated by insulin. Now I summarize. Yes, glycolysis is activated by insulin. So rate limiting enzyme of glycolysis phosphatidylkinase is activated by insulin. Link reaction pyruvate dehydrogenase. This link reaction is activated by insulin. Yes, glycogen synthesis. Rate limiting enzyme is glycogen synthase activated by insulin. HMP shunt, rate limiting enzyme glucose 6-phosphate dehydrogenase activated by insulin. Fatty acid synthesis, yes, acetyl coenzyme carboxylase, rate limiting enzyme activated by insulin. Cholesterol synthesis, rate limiting enzyme HMG coenzyme reductase activated by insulin. All these pathway are activated by insulin. Activate all these pathway, all these rate limiting enzyme. Now I can say on this page all the pathway other than this circle, this circle is mitochondria. All other pathway are occurring in cytosol. If I ask you, this TCA cycle occur in mitochondria, pyruvate dehydrogenase enzyme, this reaction occur in mitochondria. Other than these two, yes, glycolysis occur in cytosol, glycogen synthase occur in cytosol, HMP shunt occur in cytosol, fatty acid synthase occur in cytosol, cholesterol synthase occur in cytosol. So you can remember like this. Now we come to fasting state or starvation. Suppose I locked you in a room and I'm not giving food for 16 to 18 hours. Then your liver will say, don't worry, I can maintain blood glucose up to 16 to 18 hours. That early fasting means 16 to 18 hours. And liver glycogen is sufficient to maintain blood glucose up to 16 to 18 hours by glycogenolysis. I mentioned liver glycogen. Why not muscle? Muscle glycogen can't contribute blood glucose, Mnemonic. Muscle is selfish. Muscle says myself, my glycogen I will use, I will not give to blood. But liver says, okay, I will maintain blood glucose up to 16 to 18 hours. Yes, muscle can't contribute blood glucose. Muscle is selfish. Muscle says myself. This question was asked. A person who had dinner at 8 p.m. previous night tested his blood glucose level at 7 a.m. next morning, 11 hours. What is the source of blood glucose in this case? Yes, hepatic glycogenolysis. Suppose I locked you in a room and don't open up to 48 hours. Yes. Then I will say you are in fasting state. Liver will say, don't worry, don't worry. If glycogen is depleted, don't worry, I will make new glucose. So liver will do gluconeogenesis, and liver can maintain blood glucose up to 48 hours by gluconeogenesis. At the same time, liver will start beta oxidation of fatty acid. Means in fasting state up to 48 hours, predominantly gluconeogenesis is there, but beta oxidation also start. Remember, question is asked, in fasting state or starvation, yes, in fasting state, insulin decreases and glucagon increases. So hormone of fasting state is glucagon. This glucagon activate hormone sensitive lipase. Lipase will cut lipid, triglyceride, and triglyceride will be cut and fatty acid will be released. This fatty acid will enter the mitochondria and beta oxidation start. So I can say in fasting state, beta oxidation start and produce energy. That energy is used by this gluconeogenesis, but our main concern is to produce glucose by gluconeogenesis up to 48 hours. After 48 hours, up to, yes, 2 to 5 days, 48 hours to 5 days, yes, we say prolonged fasting or starvation. Yes, in prolonged fasting or starvation, liver is tired, now can't do gluconeogenesis so effectively, substrate are used. Now, liver will do predominantly beta oxidation of fatty acid. Some amount of gluconeogenesis also present. We found that liver is having plan B. Liver knows that it's a prolonged starvation and our vital organ, brain, heart, and skeletal muscle can utilize ketone body. You know, ketoacidosis is a very toxic condition. Why our body is synthesizing ketone body then? Because our body knows that most vital structure, brain, heart, and skeletal muscle utilize ketone body in starvation. So plan C of liver is that if gluconeogenesis is decreasing, then this beta oxidation will increase and will start ketone body synthesis, and these ketone body will be utilized by most vital structure in our body. So now I can say that this circle is mitochondria. This circle is mitochondria. And this beta oxidation of fatty acid occur in mitochondria. Ketone body synthesis occur in mitochondria. Ketone body utilization occur in mitochondria. Gluconeogenesis occur both in mitochondria and cytosol, but gluconeogenesis start in mitochondria. Point it out. Gluconeogenesis start in mitochondria. These pathways are occurring in mitochondria, and this glycogenolysis is outside the mitochondria. So this is occurring in cytosol. This is occurring in cytosol. And you know that glucagon is a hormone of fasting or starvation. So all these pathway means glycogenolysis, beta oxidation of fatty acid, gluconeogenesis, ketone body synthesis are activated by glucagon. Point it out. All these pathways are activated by glucagon. Now I can summarize which pathway occur in mitochondria, which pathway occur in cytosol. There are two techniques. Either you make mnemonic, you will forget. If you remember this complicated pathway, just revise once more. You will find that most of the question, integrated question, can be solved this integration. So you can't skip that. Now I can say which pathway occur in which compartment. First of all, I will discuss mitochondria. I have already told you on first page only two steps, pyruvate dehydrogenase, TCA cycle occur in mitochondria. So pyruvate dehydrogenase and TCA cycle occur in mitochondria. On this page, I have told you beta oxidation occur in mitochondria, ketone body synthesis occur in mitochondria, ketone body utilization occur in mitochondria. So ketone body synthesis, ketone body utilization occur in mitochondria, beta oxidation occur in mitochondria. We found that first page, glycolysis, glycogen synthesis, yes, glycolysis, glycogen synthesis, HMP shunt, fatty acid synthesis, cholesterol synthesis occur in cytosol. All these occur in cytosol. So I can write here Yes, glycolysis, glycogen synthesis, HMP shunt, fatty acid synthesis, cholesterol synthesis, glycogenolysis. Yes, glycogenolysis also occur in cytosol. I have discussed. So glycogen synthesis and glycogenolysis both occur in cytosol. Cytosol. And four pathway occur both in mitochondria and cytosol. Mnemonic is hug pyari. Yes, so two-person hug. So two compartment, mitochondria and cytosol, H for heme synthesis, U for urea cycle, G for gluconeogenesis, and pyari for pyrimidine synthesis occur both mitochondria and cytosol. Now, mature RBC don't contain mitochondria. So pathway involving mitochondria can't occur in mature RBC. Mature erythrocyte RBC, this is important point, means these pathway which occur in mitochondria don't occur in RBC. Yes, mature RBC. These pathway don't occur in mature RBC. Yes, heme synthesis question was asked that heme synthesis occur in erythroid precursor but not in mature erythrocyte, because mature erythrocyte mitochondria is not there. All pathway, yes, these are occurring in mitochondria, so they are not occurring in RBC. Now we discuss few diet question with the help of mnemonic. First of all, insulin. I remember insulin as insulin injection having sharp end which can cut. So mnemonic is insulin, IN for insulin, IN for incision. Insulin do incision. Insulin remove phosphate. Remove phosphate by phosphatase. Phosphatase. So insulin activate phosphatase and remove phosphate. Insulin do incision of this cyclic AMP. When it will cut this cyclic AMP will decrease. So decrease cyclic AMP. So direct question are asked: insulin decrease cyclic AMP, insulin activate phosphatase, so remove phosphate. We found that glucagon as glue, bottle of glue. This insulin cut this cyclic AMP, glucagon will join with the help of glue. They are having opposite action. You know, glucagon and insulin are exactly opposite action. So if insulin is cutting, glucagon will join with glue. So glucagon increase cyclic AMP by joining with glue. This increased cyclic AMP activate protein kinase A. This protein kinase A, kinase transfer a phosphate group on protein. So attach phosphate to protein. So you can make this concept that glucagon increase cyclic AMP, this cyclic AMP activate protein kinase A attach phosphate to protein. Or simply you can make mnemonic, glucagon attach phosphate to protein with the help of glue. So now you will remember mnemonic, conceptual mnemonic. All enzymes activated by glucagon are active in phosphorylated state. Active in phosphorylated state. Why? Because glucagon attach phosphate and activate the enzyme. If I ask you glycogen phosphorylase, that is rate limiting enzyme of glycogenolysis. Glycogenolysis is activated by glucagon. So this glycogen phosphorylase is active in dephosphorylated state or phosphorylated state? Yes, phosphorylated state, because it is activated by glucagon. Now insulin. Yes, any enzyme activated by insulin are active in a dephosphorylated state. Dephosphorylated state. So I told you that yes, fad state, first page, all the pathways are activated by insulin. All these pathways are activated by insulin. Now I summarize here. We found that insulin activate glycolysis. So phosphofructokinase 1, that is rate limiting enzyme of glycolysis, is activated by insulin and active in dephosphorylated state. Dephosphorylated state. Link reaction, pyruvate dehydrogenase is active in dephosphorylated state. Glycogen synthase, rate limiting enzyme of glycogen synthesis, is active in dephosphorylated state. Acetyl coenzyme carboxylase, rate limiting enzyme of fatty acid synthesis, is active in dephosphorylated state. Cholesterol synthesis, yes, HMG coenzyme A, reductase, rate limiting enzyme of cholesterol synthesis, active in dephosphorylated state, and all these pathways are activated by insulin. Now, very important mnemonic and question that insulin loves lipoprotein lipase. So insulin activate lipoprotein lipase. Insulin hates hormone sensitive lipase. H4 hates, L4 love. Okay, so L loves lipoprotein lipase, hates hormone sensitive lipase. So insulin inhibit hormone sensitive lipase. Now we come to carbohydrate. Carbohydrate, glucose is aldose sugar because it is having aldehyde group at carbon number 1. Fructose is keto sugar, keto 2. Keto group is present at carbon number 2. So fructose is keto sugar, glucose is aldose sugar. Disaccharide, sucrose is made up of glucose and fructose. If you see disaccharide, you will find that in all these disaccharide, one unit is glucose. You have to find another unit. In sucrose, SU4, sucrovar, Friday. So sucrovar, Friday. So sucrose is having second unit fructose. Maltose, both units are glucose. If maltose come to the cell will say mal aa gaya, means glucose is glucose. So much of glucose, so both units are glucose. Trehalose, again both units are glucose. Lactose, one unit is glucose. You have to find other unit, just add Ga, galactose. So one unit is galactose, second unit is glucose. Now recently asked question that lactulose, ulo means keto. So lactulose, one unit is galactose, second unit is fructose. So girlfriend, lactulose. Now homopolysaccharide is a polymer of same monosaccharide unit, glycogen. Is a polysaccharide made up of glucose by alpha 1,4 linkage linear chain, and there is branching is done by alpha 1,6 linkage. So we found that homopolysaccharide glycogen is polysaccharide of glucose in which branching is there. Due to branching, it is compact structure. That so much of branching is there, compact structure. Why compact? So that it can be accommodated in large amount in liver, can be stored easily. So this is branched and compact and stored in human, in liver and muscle. Glycogenin is a protein. This is glycogenin. This is primer for glycogen synthesis. So homopolysaccharide example are starch, glycogen I described, inulin, cellulose. Now heteropolysaccharide or mucopolysaccharide or glycosaminoglycan, three name: heteropolysaccharide, mucopolysaccharide or glycosaminoglycan. We found that these glycosaminoglycan are made up of acidic sugar and amino sugar, and there is sulfate, and sulfate is having negative charge. We found that all these glycosaminoglycan absorb large amount of water to make mucoid structure. That's why they are called mucopolysaccharides. So question has been asked, they absorb large amount of water or small amount? They absorb large amount of water. Due to this sulfate, they are having negative charge. And we found that they provide compressibility and prevent joint. Means when negative charge is there, they repel each other. That's why joints are not damaged. And this is the reason in arthritis, we give glucosamine. So glucosamine is used in arthritis. Recently asked question. Mucopolysaccharides, example hyaluronic acid. Question is asked, single liner, hyaluronic acid, there is no sulfate. So question is given that they will give you this image and they will ask which glycosaminoglycan is this. And you know, hyaluronic acid sulfate is not there. So if image is given, you will search for sulfate. Sulfate is there, it can't be hyaluronic acid. Sulfate is there, it can't be hyaluronic acid. Sulfate is there, it can't be hyaluronic acid. Yes, in this sulfate is not there. This is hyaluronic acid. So question was asked, they gave image of glycosaminoglycan heteropolysaccharide and they asked which heteropolysaccharide is this? And you searched for sulfate. There was no sulfate. And when there was no sulfate, you marked the answer hyaluronic acid. So first question, hyaluronic acid, no sulfate. Hyaluronic acid is present in synovial fluid. Question. It is also present in vitreous humor. And hyaluronic acid help in wound healing. H4 hyaluronic, H4 healing. Next glycosaminoglycan is creatine sulfate. Creatine sulfate. We found that there is no uronic acid. Single liner question. No uronic acid means COOH. No uronic acid in creatine sulfate. Image based question is asked, they will give you image, you will search for carboxylic group. Suppose this image is given, you saw that there is carboxylic group, it can't be creatine sulfate. This is carboxylic group, it can't be creatine sulfate. In this, there is no carboxylic group. No carboxylic group. This is creatine sulfate. So image-based question is asked. They will give you the structure. You will search for carboxylic group. If carboxylic group is not there, it is creatine sulfate. How you will remember? Kirtan. Creatine as kirtan. Wherever you do kirtan, you don't do urinal. You don't make urinal or you don't do urine. No uronic acid. Keratin, keratoconus, keratoplasty. Kerato word is used for cornea. So creatine sulfate is present in cornea and is responsible for the transparency of cornea. Recently asked question. These glycosaminoglycan are present extracellularly, but there is one glycosaminoglycan that is heparin. Name itself tells you in. In means this is intracellular. Intracellular. All other are extracellular. Next glycosaminoglycan is chondroitin sulfate. Next glycosaminoglycan is heparin sulfate. Heparin sulfate is present at glomerular basement membrane. This is glomerular basement membrane and this provides negative charge. Due to this negative charge, it provides charge selectiveness. Yes, negatively charged compounds are not excreted because they will repel. So it provides charge selectiveness, heparin sulfate. Dermatan sulfate predispose atherosclerosis, pneumonic. Dermat झूठ बोल रहा है, he is lying, डरना तो पड़ेगा. Sorry to be in Hindi, डरना तो पड़ेगा because it predisposed to atherosclerosis. We found that these glycosaminoglycans are degraded in lysosome by hydrolytic enzyme. We found that they are degraded in lysosome by hydrolase enzyme. This is lysosome. Lysosome is just like pool of acid of villain of Hindi movie. Anything you dip, that is hydrolyzed. We found that in lysosome, if hydrolase enzyme is deficient, then mucopolysaccharide will not be degraded. This mucopolysaccharide will accumulate in lysosome. So lysosomal storage disease, mucopolysaccharidosis or lysosomal storage disease, hydrolase enzyme deficient. When this mucopolysaccharide will not be degraded, they will accumulate at different places. They will deposit in bone to produce dysostosis multiplex, bullet-shaped middle phalanx. This is bullet-shaped middle phalanx. They will deposit in liver, hepatomegaly, splenomegaly, protuberant abdomen. They will produce pressure. There would be herniation, inguinal hernia. Yes. So hepatomegaly, splenomegaly leading to protuberant abdomen and umbilical and inguinal hernia. Copious nasal discharge, mucopolysaccharidosis, mucus, copious mucus nasal discharge. They will deposit in brain, intellectual disability, in cornea, corneal clouding, coarse facial feature, depressed nasal breeze, large tongue, frontal bossing would be there. These are features of mucopolysaccharidosis. You will find long clinical scenario. Don't be afraid of the clinical scenario. They will give you the catching point. Just like they will give, there is mucopolysaccharidosis type 1H. 1H is Hurler disease. In Hurler disease, iduronidase is deficient. Iduronidase is deficient. If this hydrogenase is completely deficient, complete deficiency, how you remember? Hurler disease, H4 Hurler, H4 hole, complete deficiency of hydrogenase. When complete deficiency, this lead to other symptoms including mental retardation. Point out other symptom means hepatosplenomegaly, they will give frontal bossing is there, depressed nasal breath is there, and there is mental retardation, and hydrogenase is deficient. Whenever they will give hydrogenase enzyme deficiency, immediately you may think of Hurler disease, and they gave mental retardation is also there, complete deficiency, Hurler disease. But the same clinical scenario they gave, and they gave no mental retardation. No mental retardation. That is She disease, means mucopolysaccharidosis type 1S, that is She disease, in which hydrogenase is deficient, partial deficiency. Mnemonic is, yes, she S4 slight. If slight deficiency, partial deficiency of hydrogenase, then it is She disease. There would be no mental retardation. That's why I told you they will give clinical scenario. All the points will be given. If mental retardation is there, then and hydrogenase is deficient, they will not tell you complete or partial. Yes, hydrogenase is deficient. Mental retardation is there, Hurler. No mental retardation, She disease. Now, MPS type 2, that is Hunter's disease. Yes, if you see Hunter's bungalow, you will find two guns and a lion face like this. Yes, this is Hunter. And this looks like X. All mucopolysaccharidosis are autosomal recessive, but MPS type 2, Hunter disease, is X-linked recessive. All other, yes, MPS 1, MPS 3, MPS 4, all are autosomal recessive, but MPS 2 is X-linked recessive, and X-linked recessive are more common in male. And this is Hunter disease. If you are going for hunting, your vision should be clear. So in Hunter's disease, there is no corneal clouding. If corneal clouding would be there, you will be hunted. Yes. And in this, the enzyme deficient is iduronate sulfatase, mnemonic. In type 1, one word enzyme is deficient. In type 2, two words enzyme is deficient, iduronate sulfatase, X-linked recessive, and it is more common in males. You know that shikari or hunters are usually male. एक दो डाकू हसीना होती है, and you must have heard the song मैं हूँ शिकारी कुड़िए खाली मेरा वार न जाए. Means shikari is male mostly, but may also occur in female. One disorder, that is eye cell disease. This is again lysosomal storage disease, in which there is defect in Golgi bodies. Due to defect in Golgi bodies, enzyme of lysosome will not reach to lysosome. So it is a protein targeting disorder. So eye cell disease is protein targeting disorder in which enzyme of lysosome don't reach lysosome due to defect in Golgi bodies. Inclusion cell disease, eye cell disease. Now we start carbohydrate metabolism, glycolysis. Or another name is Embden-Meyerhof pathway. First step is glucose is converted to glucose 6-phosphate by hexokinase. All kinases are transferase. First question. All kinases require magnesium as cofactor. Second question. Whenever kinase is there, either ATP is used or ATP is produced. So hexokinase, this catalyze irreversible reaction. And in this, one ATP is used. Glucose 6-phosphate is converted to fructose 6-phosphate. This fructose 6-phosphate is converted to fructose 1,6-biphosphate by phosphofructokinase. Again kinase. All kinases are transferase. Kinase require magnesium as cofactor. Kinase is used, ATP is used or produced. So in this, ATP is used. So you can say till now we have used 2 ATP, and in these hexokinase and phosphofructokinase catalyze irreversible steps. This fructose 1,6-biphosphate is converted to glyceraldehyde 3-phosphate and DHAP. Both are having 3 carbon. Yes, 3 carbon. Fructose is having 6 carbon. So 6 carbon compound is converted to two molecules having 3 carbon, and this DHAP is converted to glyceraldehyde 3-phosphate. So I can say 6 carbon compound fructose 1,6 biphosphate is converted to 2 molecules of glyceraldehyde 3-phosphate. Next enzyme is glyceraldehyde 3-phosphate dehydrogenase. In complete biochemistry, wherever you find dehydrogenase, hydrogen is removed. Hydrogen is taken up either by NAD, FAD or NADP, most commonly NAD. So here hydrogen is taken up by NAD to form NADH. Two molecules are there, that's why two NADH are produced. In this reaction, glyceraldehyde 3-phosphate is converted to 1,3-biphosphoglycerate. The second phosphate comes from inorganic phosphate. This question is asked that in this step, inorganic phosphate is used. And this NADH enter electron transport chain to produce 2.5 ATP. Two molecules of NADH will produce 5 ATP. So 5 ATP produced by this NADH. Now 1,3-biphosphoglycerate is converted to 3-phosphoglycerate by phosphoglycerate kinase. This is important because this kinase catalyze reversible step. Till now we have discussed hexokinase, irreversible step, phosphofructokinase, irreversible step, phosphoglycerate kinase, reversible step, and all kinase are transferase, require magnesium as cofactor. Either ATP is used or produced. In this ATP is produced because two molecules are there, so two ATPs are produced. So 2 ATP produced. So till now 5 ATP produced by NADH, 2 ATP produced by this reversible kinase. 3-phosphoglycerate is converted to 2-phosphoglycerate. This 2-phosphoglycerate is converted to phosphoenol pyruvate by enzyme enolase. Question is asked that enolase is inhibited by sodium fluoride. E for enolase, F for sodium fluoride. So if you want to do blood glucose estimation, you take gray vial. Mnemonic is EFG. E for enolase, F for sodium fluoride, G for gray vial. And in this vial, sodium fluoride and oxalate are there. What is the function? If you are estimating blood glucose, in this blood, RBC is there, and RBC utilize glucose by glycolysis. If you don't add sodium fluoride, then RBC will utilize this glucose. If you add sodium fluoride, RBC will not be able to do glycolysis and you will find the correct value. Suppose you took sample in the morning and you gave this sample to higher center next day and you did not add sodium fluoride. Then RBC will utilize that glucose. And when you will estimate blood glucose, that would be falsely low because most of the glucose has been eaten by RBC. That's why we add sodium fluoride, which inhibit enolase, and in gray vial. Question is asked. This phosphoenol pyruvate is converted to pyruvate by pyruvate kinase. Again kinase. All kinases are transferase, require magnesium as cofactor, but pyruvate kinase require potassium. Yes, then magnesium. So question is asked, pyruvate kinase, best answer would be potassium. Okay, if potassium is not given, cofactor is magnesium. In this, ATP is produced, 2 ATP produced. So pyruvate kinase also catalyze irreversible step. So I can say that in glycolysis up to pyruvate, there are 3 irreversible steps which are catalyzed by hexokinase, phosphofructokinase, and pyruvate kinase. These are 3 irreversible steps. Yes. And these enzymes are called regulatory enzyme. Out of these 3 regulatory enzyme means irreversible steps enzymes are regulatory enzyme. Out of these 3, one is rate limiting enzyme, that is phosphofructokinase is rate limiting enzyme. It catalyzes this step. Phosphofructokinase catalyzes this step. This is also called committed step. Committed step, and this is rate limiting enzyme. So in this glycolysis, till now, I can say that 2 ATP used, 5 ATP produced here, 2 ATP produced here, 2 ATP produced here. 2 plus 2, 4 plus 5, 9 ATP produced, 2 ATP used, net gain 7 ATP. Aerobic glycolysis, net gain 7 ATP. If you don't remember the calculation, simple mnemonic, aerobic, how many letters are there in aerobic word? 7 letters. So 7 ATP net gain. In anaerobic glycolysis, AN, how many letters? 2 letters are there. Net gain is only and only 2 ATP. Why? In anaerobic glycolysis, NADH will not produce these 5 ATP. You know that NADH enter electron transport chain and produce 2.5 ATP by oxidative phosphorylation. When oxygen is not there, anaerobic condition is there, then these 5 ATP will not be produced. When this 5 ATP will not be produced, then these two NADH will be utilized in the last step. Point out, these two NADH will be used in conversion of pyruvate to lactate, to NAD. In anaerobic condition, these two NADH are utilized in the last step, in which pyruvate is converted to lactate by lactate dehydrogenase. Okay, so end product of anaerobic glycolysis is lactate. End product of aerobic glycolysis is pyruvate. In anaerobic lactate, and the last step, this NADH is used. Question is asked. So I can say anaerobic glycolysis, 2 ATP used, and 2 plus 2, 4 ATPs are produced, so net gain of only 2 ATP. A question is asked that in anaerobic glycolysis, if starting point is glycogen, point it out. We are doing glycolysis from glucose, but if starting point is glycogen, then the net gain of ATP would be 3 ATP. Warburg effect. In cancer cell, we found that cancer cell utilize large amount of glucose in the presence of oxygen. So we can say that cancer cell utilize glucose by aerobic glycolysis. But we found that normally aerobic glycolysis end product is pyruvate. But in cancer cell, in this aerobic glycolysis, end product is lactate due to metabolic reprogramming. And when end product is lactate, net gain would be 2 ATP. So Warburg effect, aerobic glycolysis, end product is lactate, net gain 2 ATP. We found that if glucose 6-phosphate dehydrogenase is deficient, glucose 6-phosphate dehydrogenase, this is question of HMP shunt, but I will discuss here that most common enzyme deficiency leading to hemolytic anemia is G6PD deficiency. When G6PD deficiency is there, you will find in clinical scenario history of anti-malarial drug Primaquine, ingestion of Favabine, or in clinical scenario you will find hinge body is there, bite cells are there. If you find this type of clinical scenario and hemolytic anemia is there, answer is G6PD deficiency. But sometimes they don't give this detail and they simply say that in RBC lactate is increased in G6PD deficiency. This is important because second most common enzyme deficiency leading to hemolytic anemia is pyruvate kinase deficiency. So if pyruvate kinase is deficient, if this step is not occurring, then pyruvate will not be produced. When pyruvate will not be produced, then lactate will not be produced. So in RBC, in pyruvate kinase deficiency, in RBC, lactate level would be low, lactate is decreased. So question is asked, they give clinical scenario of hemolytic anemia and they say lactate is increased, the answer is G6PD deficiency. If they say lactate is decreased, the answer is pyruvate kinase deficiency. Now we come to Rappaport-Lubring cycle, in which In RBC, this 1,3-biphosphoglycerate is converted to 2,3-biphosphoglycerate by enzyme mutase. 2,3-biphosphoglycerate or 2,3-DPZ. In physiology, we have read that hemoglobin is having 4 globin chain, 2 alpha globin chain and 2 beta globin chain. Each globin chain bind to 1 molecule of oxygen. So 4 globin chain bind to 4 molecule of oxygen, and there is positive cooperative effect or positive allosteric effect. Binding of 1 molecule of oxygen increases the affinity for another oxygen molecule. This is called positive allosteric effect. And due to this positive allosteric effect, the curve, O2 dissociation curve of hemoglobin is sigmoid shape due to positive cooperative effect. Hemoglobin sigmoid shape, while myoglobin curve is hyperbolic curve. So again we come to this hemoglobin. In hemoglobin, this 2,3-DPZ will bind to beta globin chain, interact with beta globin chain. And suppose a bench is there, 4 students are already sitting, and small gap, a 5th student comes, 2,3-DPZ come, and now anyhow adjust and now do like this. 1 oxygen is removed. So 2,3-DPZ will come here and will produce dot state and will remove O2. And this is leading to shift of O2 dissociation curve towards right. Question is asked, 2,3-DPZ shift O2 dissociation curve towards right shift. So Rappaport-Lubring cycle occur in RBC. First question. And in Rappaport-Lubring cycle, no ATP, net gain ATP, no ATP produced. Yes, in this step, 2,3-DPZ is converted to 3-phosphoglycerate and no ATP is produced. Net gain is 0 ATP in Rappaport-Lubring cycle. Now we come to aerobic glycolysis again. In aerobic glycolysis, end product was pyruvate. This pyruvate is further metabolized in aerobic condition. In aerobic condition, this pyruvate will enter mitochondria with the help of H-ion symport, proton symport. So pyruvate is having 3 carbon. It will be converted to 2 carbon compound acetyl coenzyme A. Acetyl coenzyme A, acetate, acetic acid. How many carbon? 2 carbon atoms are there. Pyruvate, how many carbon? 3 carbon. So a 3 carbon compound is converted to 2 carbon compound. 1 carbon must be removed, and removal of carbon dioxide is called decarboxylation. Decarboxylation. So acetyl coenzyme is produced, CO2 is produced, and the name of enzyme is pyruvate dehydrogenase complex. It is multi-enzyme complex, and you know wherever dehydrogenase is there, hydrogen is removed. Hydrogen is taken up by NAD to form NADH, and removal of hydrogen is called oxidation. Oxidation. So I can say when pyruvate is converted to acetyl coenzyme A, there is oxidation, there is decarboxylation. So I can say this reaction is example of oxidative decarboxylation. Oxidative decarboxylation. And this is irreversible step. So this reaction is irreversible reaction. Point it out. I told you that pyruvate dehydrogenase complex is multi-enzyme complex. It is having 3 enzymatic activity, E1, E2 and E3. E1 is pyruvate dehydrogenase, E2 is dihydrolipoyl transacetylase, E3 is dihydrolipoyl dehydrogenase. Difficult to remember, we will make mnemonic. Yes, I told you that pyruvate is converted to acetyl coenzyme A. First CO2 is removed. So CO2 is removed, 3 carbon compound is going to 2 carbon compound, and then I told you NADH is produced. So I discussed in this clockwise. So you will remember like this. So first E1, although the name is pyruvate dehydrogenase, but it removes CO2. E2, the name is dihydrolipoyl transacetylase, acetyl. So it removes acetyl coenzyme A. Then E3, dihydrolipoyl dehydrogenase, it remove NADH. So why we remembered like this? Because a question was asked that enzyme that converts pyruvate to acetyl coenzyme are given in the diagram. What are the enzyme marked as E1 and E2? E1 removes CO2, that is pyruvate dehydrogenase. This is E1, remove CO2, pyruvate dehydrogenase. E2 remove acetyl coenzyme, yes, dihydrolipoyl transacetylase. So they have asked what is E1. E1 is pyruvate dehydrogenase. E2 is dihydrolipoyl transacetylase. Answer is A. So if you will remember this simple way, you will never forget that first CO2, then acetyl coenzyme, then NADH. We found that this oxidative decarboxylation cofactor is vitamin B1. O for oxidative, O for 1. That is vitamin B1 thiamine. Thiamine is cofactor. If pyruvate dehydrogenase is deficient, this step would not occur. Pyruvate will not be converted to acetyl coenzyme. In cytosol, this pyruvate will be converted to lactate by enzyme lactate dehydrogenase. This lactate dehydrogenase present in cytosol. Question is asked, lactate dehydrogenase convert this pyruvate which is not metabolized because pyruvate dehydrogenase complex is deficient, then this will produce lactate, lactic acidosis. Recently asked question in INICET, congenital lactic acidosis is due to defect of pyruvate dehydrogenase. Pyruvate dehydrogenase defect lead to congenital lactic acidosis. Now question is asked that pyruvate enter mitochondria with the help of HN import. Yes, pyruvate dehydrogenase deficiency lead to congenital lactic acidosis. Pyruvate dehydrogenase catalyze irreversible reaction and oxidative decarboxylation. And oxidative decarboxylation cofactor is vitamin B1. So if B1 is deficient, then pyruvate dehydrogenase will not be able to work. If B1 is deficient, again it will not work. Again pyruvate will be converted to lactate, lactic acidosis. So in B1 deficiency, there is lactic acidosis. And you know, B1 deficiency lead to beriberi. They will ask question in beriberi. There is lactic acidosis because pyruvate dehydrogenase is not working. Pyruvate will accumulate, will be converted to lactate. Now example of oxidative decarboxylation. Three enzyme which catalyze oxidative decarboxylation. One is pyruvate dehydrogenase, just discussed. Second is alpha ketoglutarate dehydrogenase. Third is branch chain alpha keto acid dehydrogenase. These are three enzymes which catalyze oxidative decarboxylation. Oxidative O41, the cofactor is vitamin B1. Simple decarboxylation, S for simple, S for 6. Cofactor is vitamin B6. So oxidative decarboxylation, cofactor is vitamin B1. Simple decarboxylation, cofactor is vitamin B6. Example of simple decarboxylation, glutamate to GABA, histidine to histamine, tryptophan to serotonin. So question is asked like this, that glutamate is converted to GABA by decarboxylation. They will not tell you that this is simple or oxidative. You must know that glutamate is converted to GABA by simple decarboxylation, and they will ask what is the cofactor. So you must know that this is simple decarboxylation, and in simple decarboxylation cofactor is B6. Question is asked that pyruvate is converted to acetyl coenzyme by decarboxylation. Cofactor is, you must know that this decarboxylation is oxidative decarboxylation and cofactor is vitamin B1 thiamine. Now we come to citric acid cycle, TCA cycle. We know that glucose is converted to pyruvate by glycolysis. Pyruvate enter the mitochondria. In mitochondria, by pyruvate dehydrogenase, it is converted to acetyl coenzyme. Further oxidation of acetyl coenzyme occur by this TCA cycle or Krebs cycle. We found that acetyl coenzyme having 2 carbon join with oxaloacetate having 4 carbon. Oxaloacetate 1, 2, 3, 4. sometimes I remember like this, 4 carbon. So 4 carbon compound bind with 2 carbon compound acetyl coenzyme to form citrate having 6 carbon. Citrate is having 6 carbon. Citrate synthase is the enzyme. Now this citrate is converted to isocitrate, 6 carbon, by enzyme aconitase. And this aconitase is inhibited by fluoroacetate. Frequently asked question that in Krebs cycle, aconitase is inhibited by fluoroacetate. This isocitrate having 6 carbon is converted to alpha ketoglutarate 5 carbon. So glutarate, glutamate, glutamine, 5 carbon atoms are there. So a 6 carbon compound is converted to 5 carbon compound. A carbon must be removed. Removal of carbon dioxide is called decarboxylation. And the name of enzyme is isocitrate dehydrogenase. And you know, wherever dehydrogenase is there, hydrogen is removed. It is taken up either by NAD, FAD or NADP. Most commonly NAD. So NAD take hydrogen to form NADH. And removal of hydrogen is called oxidation. So you can say when isocitrate is converted to alpha ketoglutarate, a 6 carbon to 5 carbon compound, 1 carbon is removed, that is decarboxylation, and hydrogen is removed, that is oxidation. Removal of hydrogen is called oxidation. So this is example of oxidative decarboxylation. And we have read that cofactor for oxidative decarboxylation is vitamin B1. But here, vitamin B1 is not cofactor for this oxidative decarboxylation question. Now alpha ketoglutarate having 5 carbon is converted to succinyl coenzyme. U looks like 4, having 4 carbon. So a 5 carbon compound is converted to 4 carbon compound succinyl coenzyme. So 1 carbon is removed. Removal of carbon dioxide is called decarboxylation. And the name of enzyme is alpha ketoglutarate dehydrogenase. Dehydrogenase means removal of hydrogen. It is taken up by NAD to form NADH. So you can say removal of hydrogen, oxidation, removal of carbon dioxide, decarboxylation. So it is also example of oxidative decarboxylation. And here oxidative decarboxylation, vitamin B1 is cofactor for this oxidative decarboxylation. Question is asked that CO2 is removed just before and after alpha ketoglutarate, and first CO2 B1 is not cofactor, second removal CO2 B1 is cofactor. Succinyl coenzyme is converted to succinate by thiokinase, and this thiokinase produce GTP. When kinase produce GTP, that is called substrate level phosphorylation. Question is asked that in Krebs cycle, only step where substrate level phosphorylation occur, that is catalyzed by thiokinase. Succinate is further converted to fumarate by succinate dehydrogenase. Dehydrogenase means hydrogen is removed. Till now, I have seen wherever dehydrogenase is there, every time hydrogen is taken up by NAD to form NADH. But succinate dehydrogenase, hydrogen is taken up by FAD to form FADH. This is really important. And succinate dehydrogenase is inhibited by malonate. So question is asked that malonate inhibits succinate dehydrogenase, and succinate dehydrogenase produce FADH. Mnemonic is mala suc fuck. So mala for malonate, SU for succinate dehydrogenase, F for FADH is produced. Fumarate is converted to malate. Malate is converted to oxaloacetate by malate dehydrogenase. Again, dehydrogenase NADH is produced. So I can say in this Krebs cycle, TCA cycle, yes, 3 NADH are produced. 3 NADH produce, 1 FADH and 1 GTP produce. So if I write here 3 NADH, 1 FADH and 1 GTP. NADH enter electron transport chain to produce 2.5 ATP. FADH enter electron transport chain to produce 1.5 ATP. 1 GTP is equivalent to 1 ATP. 1 ATP. So net gain of ATP 3 into 2.5, 7.5 ATP, 1.5 ATP and 1 ATP. So total, yes, 10 ATP. So question is asked, One acetyl coenzyme may enter Krebs cycle to produce 10 ATP. Mnemonic is TCA cycle, T4 TCA, T4 10 ATP are produced from one acetyl coenzyme. I just told you that NADH produce 2.5 ATP and FADH produce 1.5 ATP by electron transport chain. So how these NADH produce 2.5, FADH produce 1.5 by electron transport chain. Electron transport chain is present at inner mitochondrial membrane. This red color is inner mitochondrial membrane. And electron transport chain is made up of complexes, complex 1, 2, 3, 4, 5. So I have shown here complex 1. This is coenzyme Q. Complex 3rd, this is cytochrome C. This is complex 4. And we know NADH is having very high energy equivalent to 2.5 ATP. And we found that this hydrogen will move. Hydrogen, another is name is electron. So for question purpose, hydrogen and electron are same. Now I say this electron will move via this chain. Yes, electron will move via this chain. That's why it is called electron transport chain. So first complex is NADH coenzyme Q reductase. Another name NEAT PG24, another name they have asked NADH dehydrogenase. What is the function of this complex 1? Complex 1 take hydrogen from NADH and give to coenzyme Q. So complex 1 remove hydrogen. And if remove hydrogen, that is dehydrogenase. So actually name is NADH coenzyme Q oxidoreductase. But you will understand with the help of animation. In electron transport chain, NADH is having very high energy to produce 2.5 ATP. In this H or electron is moving. Complex 1 remove hydrogen from NADH. Removal of hydrogen is called dehydrogenation. That's why complex 1 is called NADH dehydrogenase according to question. Yes, this complex 1 take hydrogen and give to coenzyme Q. And joining of hydrogen is called reduction. So complex 1 took hydrogen from NADH and give to coenzyme Q. So coenzyme Q is reduced. That's why complex 1 is called NADH coenzyme Q reductase. Now complex 3rd will take hydrogen from coenzyme Q and will give to cytochrome C. And if you join hydrogen to cytochrome C will be reduced. That's why complex 3rd is called cytochrome C reductase. Complex 4 take this hydrogen from cytochrome C and give to oxygen. That's why complex 4 is called cytochrome C oxidase. This sequence is important. Question has been asked in NEET PG. Yes, how this hydrogen is moving or electron is moving. Hydrogen is moving via this chain or electron is moving via this chain. Electron transport chain, and question was asked this complex 4 remove hydrogen from cytochrome C. Removal of hydrogen is called oxidation. That's why complex 4 is cytochrome C oxidase. And the last acceptor of hydrogen is, last acceptor of electron is oxygen. So complex 3 name cytochrome C reductase, complex 4 name cytochrome C oxidase. And question was asked which enzyme uses molecular oxygen at hydrogen acceptor to produce water, and the answer is the cytochrome C oxidase complex 4. Yes, in complex 4 oxygen is used as a hydrogen acceptor. Now we come to complex 5. Complex 5 is made up of FO, that is HN channel, and F1, that is ATP synthase activity. Means this complex 5 convert ADP to ATP, and this complex 5 is inhibited by oligomycin. Just to complete this fill in the blank, that CO2 is removed just before and after alpha keto glutarate. Yes, this was a part of Krebs cycle. Yes, we have completed it. Now we again come to our electron transport chain. So we have discussed complex 1, complex 3rd, complex 4, complex 2 is left. We found that FADH enter electron transport chain via complex 2, and complex 2 take hydrogen from FADH and give to coenzyme Q. And complex 2 name is succinate coenzyme Q reductase. Succinate coenzyme Q reductase. This is ADP ATP translocase. This is ADP ATP translocase. What is the function? ADP bind at this site, ATP bind at this site. Just like this is ADP ATP translocase, ADP bind at this side, ATP, this rotate. ADP in, ATP out. So question is asked that ADP ATP translocase is inhibited by, yes, name itself tells you, atractyloside. A for ADP ATP, trac means yes, translocase. ADP ATP translocase is inhibited by atractyloside. Question is asked. Now inhibitors, very important, every time question, two question in NEET PG this time. Complex 1 is inhibited by rotenone. Name itself tells you ONE1. Phenobarbital ONE1, amobarbital or phenobarbital, amobarbital A41. Piercidine, if you want to pierce ear, you will take needle. Needle looks like one. Complex 2 inhibitor, malonate. Mnemonic is MS Dhoni. M for malonate, S D for succinate dehydrogenase, 2 for complex 2. दो नहीं, not 2. Complex 2 नहीं रहेगा, will be inhibited. Carboxin, carbixin, bike, car, bike. Bi means 2. TTFA, 2 times T. So complex 2 inhibitor. Complex 3 inhibitor, N3-mycin, antimycin, I pronounce it N3-mycin. BAL, British antilucide or dimercaprol. How many letters? 1, 2, 3. 3 letters are there. Complex 4, inhibitor of complex 4, carbon monoxide, cyanide, H2S, azide. All these are having ide in their last. Carbon monoxide, ide, inhibit complex 4. Cyanide, ide, inhibit complex 4. Hydrogen sulfide, ide, complex 4. Azide, ide, complex 4 is inhibited. Now, concept of uncoupler. You will remember any compound which cause H ion leakage at inner mitochondrial membrane, that is uncoupler. So if there is a pore at inner mitochondrial membrane, H ion can diffuse via this, and this is called uncoupling. So any compound which cause H ion leakage at inner mitochondrial membrane is uncoupler. Example of uncoupler, 2,4-dinitrophenol. Phenol produce whole. Phenol produce whole. Yes, leakage. Chhed. High dose aspirin. These are uncoupler. In nature, few uncouplers are found, just like thermogenin. Thermogenin is found in brown fat and responsible for non-shivering thermogenesis. This is found in nature and this act as uncoupler. So this is natural uncoupler. Other natural uncoupler are thyroxine, long chain fatty acid, unconjugated bilirubin, common example of natural uncoupler. Now we come to HMP shunt or pentose phosphate pathway, PPP. What is the function of HMP shunt? HMP shunt produce NADPH and pentose sugar. No ATP produced. Simple concept. If you want to produce energy from carbohydrate, do glycolysis. If you want to produce reducing equivalent NADPH, then do HMP shunt. If you want to produce pentose sugar, then do HMP shunt. So HMP shunt, two main function, that NADPH is produced, pentose sugar produced, no ATP produced. This is the question. First step in HMP shunt is glucose 6-phosphate is converted to 6-phosphogluconate by glucose 6-phosphate dehydrogenase. And you know, wherever dehydrogenase is there, hydrogen is removed, hydrogen is taken up either by NAD, FAD or NADP. In this, hydrogen will be taken up by NADP. You can remember easily, name of this pathway is PPP, pentose phosphate pathway. So many times P. So hydrogen acceptor is NADP to form NADPH. And this is removal of hydrogen. Removal of hydrogen is called oxidation. And this glucose 6-phosphate dehydrogenase is a rate limiting enzyme of HMP shunt. 6-phosphogluconate is converted to ribulose 5-phosphate pentose sugar, again dehydrogenase. Again hydrogen will be taken up by NAD to form NADPH, and removal of hydrogen is oxidation. So I can say up to these two steps I have discussed, these two steps are irreversible, and this is oxidative phase. So in HMP shunt there is oxidative phase, non-oxidative phase. So first phase is oxidative phase, and in this reactions are irreversible. Question: we found that ribulose 5-phosphate is converted to ribose 5-phosphate pentose sugar, which take part in synthesis of nucleotide. So I told you that main function was pentose sugar production, which is taking part in synthesis of nucleotide and production of NADPH. This phase, these reactions which are occurring in the last, they are called non-oxidative phase. And these are reversible reaction. Question on NADPH use. What are the uses of NADPH? Frequently asked question, that it is used in fatty acid synthesis. When it is used in fatty acid synthesis, wherever fatty acid synthesis occur, you require NADPH. In those organ, HMP shunt must be present. So we found that fatty acid synthesis occur in adipose tissue. So in adipose tissue, fatty acid synthesis occur, and in fatty acid synthesis, NADPH is required. So HMP shunt must be present in adipose tissue. Question: lactating mammary gland synthesize fatty acid, so HMP shunt must be present in lactating mammary gland. Conceptual question: in non-lactating mammary gland, you are not doing fatty acid synthesis, so HMP shunt is absent in non-lactating mammary gland. Cholesterol synthesis also require NADPH. Question: and this occur in liver. Liver is the main organ of metabolism. Most of the pathway occur in liver, so HMP shunt also occur in liver. This is conceptual mnemonic. We are understanding that which pathway is occurring in which organ. Then if those pathway require NADPH, HMP shunt must be present in those organs. Steroid hormone synthesis require NADPH. Steroid hormone synthesis occur in adrenal cortex, HMP shunt present in adrenal cortex. Sex hormone synthesis occur in testis, ovary, placenta, so HMP shunt present in testis, ovary and placenta. NADPH is also used to convert oxidized glutathione to reduce glutathione in RBC. So HMP shunt also occur in RBC. Lactating mammary gland, HMP shunt present. Non-lactating mammary gland, HMP shunt is absent. Question: skin, HMP shunt absent. Question: skeletal muscle, HMP shunt absent. So these are three important questions where HMP shunt is absent. What is the function of this NADPH in RBC? We can see that in RBC, reduced glutathione is converted to oxidized glutathione. And when this reduced is converted to oxidized glutathione, this H2O2 is destroyed. Peroxide, yes, oxidizing agent is destroyed. So we found that reduced glutathione can destroy this H2O2, and enzyme name is glutathione peroxidase. Prosthetic group is selenium. This oxidized glutathione is converted back to reduced glutathione with the help of NADPH. Yes, NADPH convert oxidized glutathione back to reduced glutathione. And the name of enzyme is glutathione reductase, and B2 is cofactor for this glutathione peroxidase. If glucose 6-phosphate dehydrogenase is deficient, if this enzyme is deficient, NADPH will not produce, HMP shunt would not occur. When NADPH will not be produced, then this oxidized glutathione will not be converted back to reduced glutathione. When this reduced glutathione will not be reproduced, this H2O2 will not be destroyed. This H2O2 will destroy RBC, hemolytic anemia. That's why we say that most common enzyme deficiency leading to hemolytic anemia, that is glucose 6-phosphate dehydrogenase, NADPH not produced. So oxidized glutathione is not converted to reduced glutathione, H2O2 is not destroyed, H2O2 damage RBC cell membrane, that is hemolytic anemia. Now we come to glycogen metabolism. We all know when we are in fat state, when we take diet, yes, blood glucose increases. Extra glucose is converted to glycogen. Extra glucose is converted to glycogen, and this glycogen is stored in liver and muscle. Yes, in liver, this glycogen is stored. Okay, in muscle, this glycogen is stored. So how this glycogen synthesis occur? When blood glucose is high, that extra glucose is converted to glucose 6-phosphate by enzyme glucokinase. So first enzyme is glucokinase, and this glucose 6-phosphate is produced. Now this glucose 6-phosphate is converted to glucose 1-phosphate, means phosphate was present at sixth position. Previously, it was present at sixth position. Now it is present at one position. So transfer of a group within a molecule. Transfer of a group within a molecule, that is done by mutase. Mutase transfer a group within a molecule. It is isomerase. Enzyme name is mutase or phosphoglucomutase. Now glucose 1-phosphate is converted to UDP glucose. Whenever carbohydrate want to do new work, it attach itself to UDP. So we found that this UDP glucose, suppose my hand is UDP and this cap is glucose. Now glycogen synthase will come. This glycogen synthase will take this glucose and will join this glucose to pre-existing glycogen. So suppose this is glucose, it will be joined here. So glycogen synthase transfer glucose from UDP glucose to pre-existing glycogen. So glycogen synthase is a transferase. Question: transferase, and this is rate limiting enzyme for glycogen synthesis. So this glycogen synthase make 1,4 bond, alpha 1,4 bond, but you know glycogen is branch chain compound. So there should be branching. So next enzyme is branching mnemonic. If you write small b looks like 6. So branching enzyme make alpha 1,6 bond. Question is asked. Now in this way, after joining so many glucose molecule, branching would be there, and in this way glycogen will be synthesized. So this is glycogen synthesis, in which if you don't remember all these enzymes, just remember rate limiting enzyme is glycogen synthase, which is transferase. Branching enzyme, B for branching, B looks like 6, so it make alpha 1,6 bond, and this glycogen is stored both in liver and muscle. Now glycogenolysis. In fasting state, when you are not taking food, we can maintain blood glucose up to 16 to 18 hours. We know that our liver is having so much amount of glycogen which is sufficient to maintain blood glucose up to 16 to 18 hours. Means if you are in fasting, if I lock you in a room and don't give food, your liver glycogen will maintain blood glucose by glycogenolysis. I am talking about again liver. Liver will maintain blood glucose by glycogenolysis. Muscle is also having glycogen. But muscle is very selfish. Muscle says myself. Yes, muscle says I will not give my glycogen to anybody. I will utilize my glycogen for production of energy for myself. So muscle don't contribute blood glucose. Yes, muscle can't contribute blood glucose. Point it out. Now we start glycogenolysis. In muscle and liver both, enzyme is glycogen phosphorylase. This is rate limiting enzyme. If this glycogen phosphorylase is present in muscle, that is muscle phosphorylase. If this glycogen phosphorylase is doing its action in liver, that is liver phosphorylase. What is the function? This phosphorylase will cut glucose, and this glucose is released as glucose 1-phosphate. This glycogen is broken down and glucose is released as glucose 1-phosphate. Other than this glycogen phosphorylase, 2 enzymes are also important. Those are glucan transferase and debranching enzyme. What is the exact function? I don't care. Just remember debranching. B for 6. B looks like 6. So debranching enzyme will cut alpha 1,6 bond. Question is asked that branching enzyme form which bond? Alpha 1,6. Debranching enzyme cut which bond? Alpha 1,6. Other than branching and debranching enzyme, all other enzyme will make or cut alpha 1,6 bond. Remember this point. So if I ask you, glycogen synthase make which bond? You know alpha 1,4 because other than branching and debranching, all other form or cut alpha 1,4. Now, this glucose 1 phosphate is produced. So I can say both in muscle and liver, this glycogen phosphorylase will release glucose as glucose 1 phosphate. This glucose 1 phosphate will be converted to glucose 6 phosphate by same enzyme mutase, and I will draw here, this is reversible reaction. This is reversible reaction. So I can say this mutase or phosphoglucomutase is common to both glycogen synthesis and glycogenolysis. Question is asked, enzyme common to glycogen synthesis and glycogenolysis is phosphoglucomutase. This glucose 6 phosphate is the end product in muscle. In muscle, end product of glycogenolysis is glucose 6 phosphate because the last enzyme glucose 6 phosphatase, which convert glucose 6 phosphate to glucose, is absent in muscle. So point it out that if glucose is free in the cell, it can come out of the cell, it can enter the cell. But if glucose is joined with phosphate, now ye फंस गया. So glucose 6 phosphate can't come out of the cell. So in muscle, when glycogen is broken down, the end product is glucose 6 phosphate. This glucose 6 phosphatase is absent in muscle. That's why end product is this glucose 6 phosphate. Glucose 6 phosphate can't come out of muscle cell to blood. So this glucose 6 phosphate can't come out of cell to blood. So that's why muscle glycogen can't contribute blood glucose due to deficiency of glucose 6 phosphatase. Question. And in liver, this glucose 6 phosphatase is present, and this glucose 6 phosphate will be converted to glucose, and glucose will diffuse out of liver cell into blood. So liver glycogen can maintain blood glucose up to 16 to 18 hours by glycogenolysis. I just told you that muscle says myself, my glycogen, I will produce energy, and we found that if muscle utilize glycogen for energy production in anaerobic glycolysis in muscle from glycogen produce 3 ATPs. Normally anaerobic glycolysis produce 2 ATP, but if starting point is glycogen, net gain is 3 ATP. And whenever muscle do exercise, anaerobic glycolysis, lactate will be produced. So after exercise, lactate level will increase. Now we come to glycogen storage disease. If glycogen metabolism is defective in muscle, then it is muscle glycogen storage disease. If glycogen metabolism is defective in liver, then it is liver glycogen storage disease. So I just told you that when we do exercise, muscle utilize glycogen to produce energy. So if you are doing exercise and muscle glycogen metabolism is defective, you can't produce energy because muscle glycogen metabolism is defective, then you will say you can't do exercise intolerance. So if question is asked on glycogen storage disease, they will tell you the catching point. They told that patient is having exercise intolerance. You will understand that muscle glycogen storage disease is there. Why? Because muscle will not be able to produce energy from glycogen. Example of muscle glycogen storage disease are type 5 glycogen storage disease, that is myocardial disease. In myocardial disease, muscle phosphorylase is deficient. So yes, this muscle phosphorylase is deficient. This is type 5 glycogen storage disease, that is myocardial disease, means muscle will not be able to break down glycogen, so muscle will not be able to produce energy, and when you will try to do exercise, you will be not able to do exercise intolerance, and even there then you will do exercise, muscle cell death would occur, myoglobin will release, myoglobin will come in urine, burgundy color of urine. So that is rhabdomyolysis, burgundy color of urine, burgundy colored urine. So muscle glycogen is not broken down. When muscle glycogen is not broken down, lactate will not be produced. So it is catching point in question that in myocardial disease, lactate level would be decreased low. Because muscle glycogen is not broken down anaerobically, lactate will not be produced, lactate would be low. So muscle glycogen storage disease, one I discussed, myocardial. Second, type 2 glycogen storage disease, that is Pompey's disease. Type 2, we are pumping with the help of two hands. Yes, and heart is enlarging, hypertrophic cardiomyopathy. Type 2 Pompey's disease, in this there is hypertrophic cardiomyopathy and heart failure. Death occur due to heart failure. So till now you know that we pump with two hands. So type 2 Pompey's and death occur due to heart failure. And I told you heart is enlarged, there is hypertrophic cardiomyopathy. Now we make a conceptual mnemonic. Type 2, we found that some amount of glycogen is metabolized in lysosome with the help of acid maltase. I told you that normally glycogen is degraded by this glycogen phosphorylase, but we found a small amount, approximately 2% of glycogen is degraded in lysosome by enzyme alpha-1,4-glucosidase, or another name is acid maltase. If this acid maltase is deficient, then it causes Pompey's disease, type 2 glycogen storage disease. When this enzyme is deficient, glycogen will accumulate in lysosome, lysosomal storage disease. So type 2 glycogen storage disease is also lysosomal storage disease. Now mnemonic of 2. Type 2 Pompey's disease, 2% of glycogen is metabolized in lysosome. Question. Enzyme defect is acid maltase. How you remember? Maltose is made up of two molecules of glucose. So 2, mnemonic of 2 glucose, enzyme maltase, acid maltase, type 2 glycogen storage disease. It is both glycogen storage disease and lysosomal storage disease. And in this you will find that muscles are also affected, hypotonia would be there, floppy infant would be there. Sometimes you will find image, a baby on palm and a floppy infant is there. And in clinical scenario, you will find that they will give, yes, 2-month-old infant, floppy infant is there, hypertrophic cardiomyopathy, recently NEET PA24, they gave X-ray. In that X-ray, heart shadow was large. Yes, hypertrophic cardiomyopathy. Answer is type 2 glycogen storage disease, Pompey's disease. Now we come to liver glycogen storage disease. You know, liver maintains blood glucose in fasting state. If liver glycogen is not broken down, there would be fasting hypoglycemia. When fasting hypoglycemia would be there, glycogen is not broken down, glycogen will accumulate in liver, hepatomegaly. So if hepatomegaly and fasting hypoglycemia is there, immediately you will think of liver glycogen storage disease. First of all, I will mention the name and enzyme deficiency of these liver glycogen storage disease, then I will describe in detail. Type 1 glycogen storage disease, Vaughan-Girkes disease. Mnemonic is Vaughan as pronounced 1. Type 1 glycogen storage disease. Enzyme defect is glucose 6-phosphatase. Type 6 glycogen storage disease, that is Hur's disease. Enzyme defect is liver phosphorylase deficiency. Type 4 glycogen storage disease, that is Anderson disease. In this, branching enzyme is deficient. Type 3 glycogen storage disease, Cory's disease, in which debranching enzyme is deficient. So first of all, again repeat, type 1, Vaughan-Girkes, glucose 6-phosphatase deficient. Type 6, Hur's disease, liver phosphorylase deficient. Type 4, Anderson disease, branching enzyme deficient. Type 3, Cory's disease, debranching enzyme deficient. Now I make mnemonic and concept. If hepatomegaly and fasting hypoglycemia is there, we can do liver biopsy. On liver biopsy, if you find abnormal glycogen in liver, then you will think of type 3 and type 4. Mnemonic is abnormal, AB, ABCD. Mnemonic is ABCD. A for Anderson disease, A for Anderson disease, B for branching enzyme. deficient. C for Cory's disease, D for debranching enzyme deficient. You can remember A, B, C. Third letter is C. So Cory's disease, third letter, type 3 glycogen storage disease. Cory's disease, debranching enzyme is deficient, and we found that in these patients, sometimes patient recover spontaneously. Means first of all, fasting hypoglycemia is there, hepatomegaly is there. When this child reach adult height, these symptoms resolves. So you can say Cory's disease cures itself. Mnemonic is Cory's disease cures itself. A question is asked that a 6-month-old child presented with fasting hypoglycemia, hepatomegaly, growth retardation. Once this child reaches puberty, he has no longer hypoglycemia, hepatomegaly, reached normal adult life. Means that is patient cures itself. Cures itself means Cory's disease. Cures itself, you can use another word that it is self-limiting. These are mnemonic. So Cory's disease cures itself and it is self-limiting. We can write like this, self-limiting. So mnemonic, self-limiting means another name is limited dextrinosis. Cory's limited dextrinosis, another name is 4B's disease. I will write 4B's disease 3 times. 4B, 4B, 4B means before 4. What is before 4? 3. So type 3 is 4B's disease. Again, I am repeating why it is important. When questions are asked, they usually confuse between Farber. In Farber disease, ceramidase is deficient. In Fabry's disease, alpha-galactosidase is deficient. 4B's disease, another name of Cory's disease or limited dextrinosis, abnormal glycogen is accumulated and debranching enzyme is deficient. Now, type 4, A for Anderson disease, A for amylopectinosis, AA. So, amylopectin-like compound is accumulated. So, Anderson name itself tells you end of sun, beta mar jayega. End of sun means death up to 4 years. Normally written 5 years, but I have taken 4 years. Why? You will remember Anderson disease is type 4. Again, I am saying abnormal glycogen A, B, C, D. So multiple time you will get long clinical scenario, and in that clinical scenario, they will give you that there is abnormal glycogen accumulated in liver. And they will give option. Yes, option A, von Gierke's disease. Option B, Hurst disease. Option C, Anderson disease. So out of these, answer would be Anderson disease, because you know that type 1 and type 6 glycogen is normal. Okay. Now, normal glycogen on liver biopsy, if you find normal glycogen, it may be type 1 or type 6. In type 1 von Gierke's disease, glucose 6-phosphatase is deficient, and you will find that this glucose 6-phosphatase is also enzyme for gluconeogenesis. So glucose 6-phosphatase enzyme is common enzyme for glycogenolysis and gluconeogenesis. First question, if glucose 6-phosphatase is deficient, this glucose 6-phosphatase is normally absent in muscle. This enzyme is not found in muscle. So in von Gierke's disease, muscles are not affected. First question, many time catching point in clinical scenario, muscles not affected. Muscles not affected. And you know, gluconeogenesis occur in liver and kidney. Yes, so gluconeogenesis, yes, this enzyme also involved in gluconeogenesis. So gluconeogenesis is also affected in this. So in von Gierke's disease, gluconeogenesis is also affected, means kidney is also affected. Renomegaly, this is catching point. Whenever question clinical scenario is there and you find the word renomegaly, immediately think of type 1 glycogen storage disease. 2-year-old boy presented with fasting hypoglycemia, hepatomegaly, kidney are enlarged. That is type 1 glycogen storage disease. In type 1 glycogen storage disease, lactic acidosis is there, hyperuricemia is there, triglyceride, cholesterol. So renomegaly, increased lactic acid, increased uric acid, increased triglyceride, increased cholesterol, that is von Gierke's disease. In Hers disease, in which liver phosphorylase is deficient, yes, no renomegaly, no lactic acidosis, no hyperuricemia, no triglyceride or cholesterol increase. So you can easily differentiate normal glycogen. Yes, you can differentiate type 1 and type 6. Abnormal glycogen, yes, Anderson and Ofson, death up to 4 years. Cory's disease cures itself, means adulthood, patient may be normal, and cure itself means self-limiting, limit dextrinosis. Limit dextrinosis. Question is asked, which compound is accumulated in Cory's disease? Limit dextrin is accumulated. And Anderson disease, which compound is accumulated? That is amylopectin like compound is accumulated. Now we discuss regulation, reciprocal regulation. We all know that glycogen is broken down to glucose, that is glycogenolysis. In muscle, when glycogen is broken down, then the end product is glucose 6-phosphate in muscle. But in liver, when glycogen is broken down, then the end product is glucose. And the rate limiting enzyme of glycogenolysis is glycogen phosphorylase. I remember glycogen phosphorylase as Thanos. Yes, a half population gone, means it break down glycogen. Glycogen phosphorylase is Thanos. Now glucose can be converted to glycogen by glycogen synthase. Yes, rate limiting enzyme for glycogen synthesis. These are two opposite pathways. These must be regulated in such a way when one is activated, other should be kept in inhibited state. Concept is that in fasting state, this glucagon epinephrine, yes, fasting state glucagon increases. This glucagon epinephrine increase cyclic AMP. This cyclic AMP activate protein kinase A. Protein kinase A. This protein kinase A attach phosphate group to glycogen phosphorylase. Attach phosphate group here. And protein kinase A also attach phosphate group to glycogen synthase. Phosphate. Phosphate means energy. We found that few enzymes are activated by phosphorylation. This glycogen phosphorylase is Thanos and it became more powerful. Yes. While glycogen synthase is inactivated by phosphorylation. Yes, it is Iron Man. He died by high power. So you can remember that Iron Man is glycogen synthase and died due to high energy, yes, inhibited by phosphorylation. While Thanos, glycogen phosphorylase is activated by phosphorylation, yes. So two opposite pathway regulated in such a way. Now a question is asked that how many stones were there? 6 stones. So glycogen phosphorylase, yes, B6 is cofactor. Question is asked, glycogen phosphorylase, vitamin B6 is cofactor for glycogen phosphorylase. Thanos, 6 stones, mnemonic. Now activator of glycogen phosphorylase. In liver, I told you glucagon, epinephrine, they increase cyclic AMP and activate glycogen phosphorylase. But in muscle, glucagon is not activator of glycogen phosphorylase. Epinephrine, yes, activator. In muscle, there is one more activator, that is calcium. Nature is very wise. Whenever you will start exercise, when you start exercise, calcium is released and this calcium will activate glycogen phosphorylase, because if you started exercise, it means now you are going to utilize glycogen and glycogen should be broken down with the help of activation of glycogen phosphorylase. So calcium is activator of glycogen phosphorylase in muscle. Inhibitor of glycogen phosphorylase, end product inhibition. So end product of liver glycogen. Liver glycogen is broken down to glucose 6-phosphate, then glucose, and energy is produced. So inhibitor of glycogen phosphorylase in liver, yes, glucose is end product, glucose 6-phosphate is produced, energy is produced, they are inhibitor. But in muscle, end product is glucose 6-phosphate, not glucose. So glucose is not inhibitor in muscle. Yes, so glycogen phosphorylase, glucose is not inhibitor. Otherwise, glucose 6-phosphate and ATP are inhibitor of glycogen phosphorylase in muscle. A question was asked that if glycogen synthase is deficient, this is called type 0 glycogen storage disease. Type 0. And when glycogen synthase is not there, glycogen will not be synthesized. So if you will do liver biopsy, in liver glycogen would not be there. So this was a question that 4-year-old child present with easy fatigability. Mother also complained that child has increased hunger between the meals, which is relieved after food. Liver examination revealed no glycogen. No glycogen is there. That is type 0 glycogen storage disease. Glycogen synthase is deficient. This question, simple adolescent male present with exercise intolerance, means muscle glycogen storage disease, crampon expulsion. Yes, myophosphorylase is deficient, myocardial disease. Now we come to gluconeogenesis, synthesis of new glucose. If I take two molecules of pyruvate, pyruvate is having 3 carbon, two molecules join to make one molecule of glucose having 6 carbon. That is gluconeogenesis. But we have read that glycogen is broken down by glycolysis and it produced 2 molecules of pyruvate. So I can say glycolysis means conversion of glucose to pyruvate, and gluconeogenesis means joining of 2 pyruvate to make glucose. These are 2 opposite pathways. For the time being, we can make mnemonic that 2 molecules of 3 carbon compound make glucose having 6 carbon. Mnemonic of 2, mnemonic of 3. Mnemonic of 2 means that gluconeogenesis occur in 2 compartment, 2 condition, 2 organs. Mnemonic of 2. 2 compartment mean gluconeogenesis occur both in mitochondria and cytosol. We have learned mnemonic hug pyari. H for heme synthesis, U for urea cycle, G for gluconeogenesis, pyari for pyrimidine synthesis occur both in mitochondria and cytosol. So gluconeogenesis occur both in mitochondria and cytosol. 2 condition, gluconeogenesis occur in starvation and diabetes. In starvation, in fasting state, you are not taking diet, there is no glucose in blood. Liver will try to maintain blood glucose by gluconeogenesis. Liver is the main organ of metabolism. It is the responsibility of liver to maintain blood glucose. If you are in fasting or starvation, liver will try to maintain blood glucose by gluconeogenesis. So gluconeogenesis occur in starvation. In diabetes, blood glucose is high but will not enter the cell. Cell will think there is no glucose, will do gluconeogenesis. So gluconeogenesis occur in starvation and diabetes. And I told you 2 organs. Liver is husband, girlfriend, or wife is kidney. So liver and kidney synthesize glucose by gluconeogenesis, mainly liver. Kidney also helps. Now mnemonic of 2 we have discussed. Mnemonic of 3, any 3 carbon compound may be a good substrate for gluconeogenesis. Again I repeat, any 3 carbon compound may be, not always, good substrate for gluconeogenesis. Why? If you take 2 molecules of 3 carbon compound, join 6 carbon glucose. So substrate for gluconeogenesis, you can easily remember pyruvate is having 3 carbon, substrate for gluconeogenesis. Lactate is having 3 carbon, substrate for gluconeogenesis. Propionic acid having 3 carbon, substrate for gluconeogenesis. Glycerol is CH2OH, CHOH, CH2OH. Sometimes it appears E. How many carbon? 3. And any 3 carbon compound may be good substrate for gluconeogenesis. We found that out of 20 amino acid, 18 amino acid may be substrate for gluconeogenesis. Out of 18 amino acid, we found that 14 amino acid are pure glucogenic amino acid. Means out of 20 amino acid, 18 amino acid can synthesize glucose. Out of 18, 14 amino acid are pure glucogenic. But out of 18, 4 amino acid, yes, are both glucogenic and ketogenic. Yes, mnemonic is tip, 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 barsa, pani, pani mein aag. Pani and aag means both glucogenic and ketogenic. Those, that is tip. T for tyrosine, T for tryptophan. I for isoleucine, P for phenylalanine. So these are 4 amino acid which can give rise to both glucose and ketone bodies. Remaining 14 only glucogenic, Out of these 14 amino acids which are pure glucogenic, we found that alanine is most important glucogenic amino acid. You know, amino acid, this is common structure to each and every amino acid. This is alanine. Even if you don't remember the structure, it's okay, but have an idea. Yes, alanine is having how many carbon? 3 carbon, and I told you mnemonic, any 3 carbon compound may be good substrate for gluconeogenesis. So most important glucogenic amino acid is alanine. Yes. So 18 amino acid may be substrate. If you don't remember what are the substrate, at least remember what are never substrate for gluconeogenesis. Not substrate for gluconeogenesis, they are ketone bodies. Ketone bodies, 3 compounds are named as ketone bodies. Beta hydroxybutyrate, acetoacetate, acetone. These are 3 compounds which are termed as ketone bodies. And we found that these ketone bodies are food of brain, heart, skeletal muscle. Means most vital structure, brain, heart and skeletal muscle utilize ketone body in starvation. That's why nature decided that these ketone bodies are food for most vital structure. Liver, don't convert these ketone body to glucose. Why? Because if liver will convert these ketone body to glucose and release these ketone body converting to glucose into blood, now in blood glucose will be utilized by different cells and brain will get babaji ka tullu. That's why nature said no, 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 these are food for most vital structure. You will not convert, means these are never substrate for gluconeogenesis. Acetyl coenzyme is not substrate for gluconeogenesis. Question. Fat are not substrate for gluconeogenesis. Carbohydrate can be converted to fat, but fat cannot be converted to carbohydrate. Question. Exception. Yes, propionic acid, 3 carbon, glycerol, 3 carbon. Yes, these are part of fat. But in spite of being part of fat, they are substrate for gluconeogenesis. Yes, I told you, mnemonic, any 3 carbon compound may be substrate for gluconeogenesis. Propionic acid, glycerol are substrate for gluconeogenesis. Otherwise, fatty acid, fat are not substrate for gluconeogenesis. Yes, exception these. Pure ketogenic amino acid, out of 22 amino acids are pure ketogenic. Mnemonic is leucine, lysine. Yes, Lily, don't be silly. Yes, leucine and lysine. Lily ask their boss, should we synthesize glucose? Then Ajit said, no, we are willing. We don't synthesize glucose. Lily, don't be silly. So they are never substrate for gluconeogenesis. Frequently asked question. Now we come to steps of gluconeogenesis. I start gluconeogenesis from pyruvate. Pyruvate is having 3 carbon, is converted to oxaloacetate having 4 carbon. When a 3 carbon compound is converted to 4 carbon compound, 1 carbon must be joined. Joining of carbon dioxide is called carboxylation. So name of enzyme is pyruvate carboxylase. So pyruvate 3 carbon compound is converted to 4 carbon oxaloacetate, and in this CO2 is joined with the help of enzyme pyruvate carboxylase. And wherever you will find the carboxylase, mnemonic is ABC. A for ATP is used, B for biotin is used, C for carbon dioxide is used. So this pyruvate carboxylase require ATP, biotin and carbon dioxide. Now acetyl coenzyme is very important activator of pyruvate carboxylase. Listen carefully. Acetyl coenzyme is activator of gluconeogenesis. It is not substrate. It is not substrate. It is activator of gluconeogenesis. Both are question. Now oxaloacetate is converted to malate. Malate comes out of the mitochondria, converted to oxaloacetate. This oxaloacetate is converted to phosphoenol pyruvate by phosphoenol pyruvate carboxykinase. Second enzyme of gluconeogenesis. Then fructose 1,6 biphosphate is converted to fructose 6 phosphate by fructose 1,6 biphosphatase. Yes. So I have left few intermediate reactions, not so important. but few reactions are also there. Yes, fructose 6-phosphate is turned into glucose 6-phosphate, and the last step of gluconeogenesis, that is glucose 6-phosphate to glucose by glucose 6-phosphatase, which is present in smooth endoplasmic reticulum. Remember, yes, this is the same enzyme which was last step of glycogenolysis. In glycogen breakdown, the last step was catalyzed by glucose 6-phosphatase. The same enzyme is also in gluconeogenesis in last step, and we know that this enzyme is deficient in von Gierke's disease. That's why in von Gierke's disease, neither gluconeogenesis nor glycogenolysis. That's why in von Gierke's disease, severe fasting hypoglycemia was there. So these are four enzyme important for gluconeogenesis, and all these four enzymes are activated by glucagon and inhibited by insulin. Now, if you take raw egg contain avidin. Avidin bind to biotin and inhibit the absorption of biotin. Yes, whenever you are doing exercise, sometimes some person will suggest that raw egg is very powerful thing. Yes, you should take. Yes, and a person is taking large amount of raw egg. Raw egg will contain avidin. This avidin will bind to biotin and inhibit the absorption of biotin. There would be biotin deficiency. If biotin deficiency would be there, pyruvate carboxylase will not work. Gluconeogenesis will not be there. There may be hypoglycemia. Gluconeogenesis is not there. That may lead to hypoglycemia. So question is asked that a child present with thinning of hair, scaling of scalp. Yes, these are symptoms of B7, that is biotin deficiency. B7, 7 as heaven, 7 as heaven, and that's why it is called vitamin H. So vitamin B7 or biotin or vitamin H deficiency lead to thinning of hair, scaling of scalp. And on taking further history, it is found that she consumes raw eggs. So they have given symptoms of biotin deficiency. They have also given the cause of biotin deficiency, that consumes raw egg regularly. Given manifestation are due to deficiency of which of the following vitamin? Answer is biotin. I told you that glycolysis and gluconeogenesis are two opposite pathway. You can see that glucose is converted to pyruvate, that is glycolysis. If I join two molecules of pyruvate, it will produce glucose, that is gluconeogenesis. So we found that all the steps of glycolysis are also involved in gluconeogenesis. You can understand, if I push glycolysis in this direction, it is converted to pyruvate. If all the steps of glycolysis would have been reversible, then life would have been very simple. But no, all steps are not reversible. Otherwise, life would be very simple. Yes, push upward, gluconeogenesis. Push downward, glycolysis. But no, three irreversible steps are there in glycolysis. So three irreversible steps are catalyzed by, yes, hexokinase, phosphatokinase, pyruvate kinase. So this is the statement: all enzyme of glycolysis are used in gluconeogenesis except hexokinase, phosphatokinase, pyruvate kinase. So you can say these four enzymes are specific to, yes, these four enzymes are specific to gluconeogenesis, and these three enzymes are specific for glycolysis. All other enzyme of glycolysis are common to glycolysis and gluconeogenesis. Question, recently asked question in INI. Enzymes: pyruvate kinase is specific for glycolysis. Phosphoenol pyruvate carboxykinase, yes, phosphoenol pyruvate carboxykinase, that is specific for gluconeogenesis. Gluconeogenesis. Pyruvate carboxylase, that is specific for gluconeogenesis. Glyceraldehyde 3-phosphate dehydrogenase. This is common for both glycolysis and gluconeogenesis because it is reversible reaction. Yes, phosphoglycerate kinase common to glycolysis, gluconeogenesis. Enolase common to glycolysis, gluconeogenesis. But most of time they ask question on glyceraldehyde 3-phosphate dehydrogenase, just like in this question. So I can say this is gluconeogenesis, this is gluconeogenesis and glycolysis, both glycolysis, but they have asked which of the following enzyme are involved in gluconeogenesis. So 2, 3, 4. Yes, 2, 3, 4 are involved in gluconeogenesis. So again, two opposite pathways are regulated. Yes, we found that glycolysis is conversion of glucose to pyruvate. Gluconeogenesis, two pyruvate join to make glucose. And we found that in fat state, when you are having sufficient amount of glucose, glucose is converted to glucose 6-phosphate, then fructose 6-phosphate. This fructose 6-phosphate is converted to fructose 2,6-biphosphate by phosphofructokinase 2. And you will write that this fructose 2,6-biphosphate indicate that glucose is in sufficient amount. So if glucose is present in sufficient amount, is there any need of gluconeogenesis? No. So nature decided that this fructose 2,6-biphosphate will inhibit gluconeogenesis. Why? Because fructose 2,6-biphosphate indicate glucose is in sufficient amount, no need of gluconeogenesis. So enzyme of gluconeogenesis, that is fructose 1,6-biphosphatase, is inhibited by this fructose 2,6-biphosphate. If you will remember the name, it would be difficult to retain. Remember the concept. Yes, this fructose 2,6-biphosphate is inhibitor of gluconeogenesis, and two opposite pathways are regulated in such a way when this is inhibited, glycolysis should be activated. So this fructose 2,6-biphosphate is activator of glycolysis, and glycolysis rate limiting enzyme is, yes, rate limiting enzyme is phosphofructokinase 1. So this fructose 2,6-biphosphate activate phosphofructokinase 1 and this inhibit fructose 1,6-biphosphatase. Now we come to reducing property of carbohydrate. All monosaccharides are reducing sugar. All monosaccharide, it may be glucose, fructose, mannose, galactose, all are monosaccharide. They are having free functional group. Aldehyde and keto group are free. So they all are reducing sugar. Questions are asked on two sugar which are non-reducing sugar. Sucrose and trehalose are disaccharide which are non-reducing. Mnemonic is no rest. No means non-reducing. RE for reducing, S for sucrose, T for trehalose. Now you are preparing, you will not take rest. And we found that all reducing sugar give Benedict test positive. Benedict test positive. Non-reducing sugar will give Benedict test negative. Benedict test, if we take urine sample and in this sample sugar is there, reducing sugar is there, then the color will change. If no reducing sugar, the color will remain blue. But if concentration of reducing sugar is 0.5 to 1 gram percent, it will be green. If 1 to 1.5 gram percent, it would be yellow. How you will remember sequence? Vibgyor. Just remove VI, blue, green, yellow, orange, red. So Benedict test is telling you the quantity of reducing sugar in the form of range. This test is not telling you the exact quantity, but it is telling you the range. That's why it is called semi-quantitative test. Sometimes this is the real picture you may find in question. Benedict test result. Now we come to galactose metabolism. Galactose is converted to galactose 1-phosphate by galactokinase. First step in galactose metabolism. If galactokinase is deficient, this is called minor type of galactosemia. Minor type of galactosemia. So first step, galactokinase. If galactokinase is deficient, this galactose will accumulate. This galactose will increase in blood. and this galactose will be freely filtered in glomeruli. So galactose increases in blood, it will be filtered by glomeruli, but renal threshold of galactose is very high. Renal threshold of galactose is high, so galactose is reabsorbed in blood up to maximum amount. So it is maximally reabsorbed. In spite of maximum reabsorption, galactose is very high in blood. So in spite of maximum reabsorption, some amount come in urine. When galactose is monosaccharide, all monosaccharide are reducing sugar. So this galactose is present in urine. So it will give Benedict test positive. So I can say that in minor type of galactosemia, galactokinase deficient, galactose will increase. This will be filtered in glomeruli and now come in urine, so Benedict test positive. And it will be reabsorbed, so it will also increase in blood. When it will increase in blood, extra galactose will be converted to galactitol by aldose reductase. This galactitol will accumulate in lens to produce oil drop cataract. Question is asked that oil drop cataract is found in galactosemia. Oil drop cataract is due to accumulation of galactitol. Question. Oil drop cataract is due to accumulation of dulcitol. Another name of galactitol is dulcitol, mnemonic. Yes, in winters, girl usually discuss your skin is so oily, your skin is looking so dull. So girl, dull, oily cream. So oil drop cataract is related to galactosemia, and the compound is galactitol or dulcitol. This is a minor type of galactosemia. Only and only symptoms, point it out, only and only symptom is cataract, and that is oil drop cataract. Next step, galactose 1 phosphate is converted to UDP galactose, and the name of enzyme is galactose 1 phosphate uridyl transferase. If this enzyme is deficient, then it is called classical type of galactosemia. If this is deficient, classical type of galactosemia. This step will not occur. When this step will not occur, galactose 1 phosphate will accumulate. This galactose 1 phosphate is inhibitor of glycogen phosphorylase. You know, liver is having glycogen, and glycogen is broken down by rate limiting enzyme glycogen phosphorylase. So we found that this galactose 1 phosphate is inhibitor of glycogen phosphorylase. It inhibits indirectly. We are not concerned with the mechanism. So when this glycogen phosphorylase will be inhibited, glycogen will not be broken down. So this glycogen will not contribute blood glucose. So blood glucose will not be maintained. That will lead to fasting hypoglycemia. And this glycogen will not be broken down. This glycogen will accumulate, and this galactose 1 phosphate will accumulate. So galactose 1 phosphate accumulate, glycogen accumulate, lead to hepatomegaly. You have learned that hepatomegaly, fasting hypoglycemia also present in glycogen storage disease. Just point out. I will differentiate it with glycogen storage disease for the time being, fasting hypoglycemia and hepatomegaly. Whenever you see in question, immediately you start thinking about liver glycogen storage disease, but it is also found in classical galactosemia. Why? Because this galactose 1 phosphate inhibit glycogen phosphorylase. This galactose 1 phosphate sequester all phosphate, and it is deposited, so it lead to mental retardation or intellectual disability. Liver is disturbed, liver function is affected, so jaundice would be there. So these are symptoms of classical galactosemia due to this galactose 1 phosphate. But when galactose 1 phosphate would be high, then further galactose will not be converted to galactose 1 phosphate, so galactose will increase. This galactose will be freely filtered via glomeruli. It will be reabsorbed again, but some amount will come in urine. So galactose will be in urine, Benedict test positive. So in minor type of galactosemia, Benedict test positive. In classical galactosemia, same concept, Benedict test positive. In minor type of galactosemia, extra galactose is converted to galactitol or dulcitol to produce oil drop cataract. In classical type of galactosemia, again galactose is high, so again galactitol and oil drop cataract. So you will differentiate. In classical galactosemia, multiple symptoms are there, but in minor type of galactosemia, only and only oil drop cataract. Point it out. Now we come to fructose metabolism, and then I will compare all the disorders. Fructose metabolism, you know, fructose is a fruit sugar. Fructose is a fruit sugar. Fructose is converted to fructose 1 phosphate by fructokinase, first step. And if this fructokinase is deficient, this is called essential fructose urea. In this, if fructokinase is deficient, this fructose will not be converted to fructose 1 phosphate. This fructose will accumulate. This extra fructose will be freely filtered by glomeruli. We found that renal threshold of fructose is low, so it will be excreted in urine. It will not increase in blood. So again point out, yes, in essential fructose urea, this fructokinase is deficient, fructose will increase, this fructose will be freely filtered via glomeruli, it will be reabsorbed in some amount but not large because renal threshold is low, so most of the fructose will be excreted in urine. So fructose in urine. And fructose is monosaccharide, reducing sugar, and reducing sugar give Benedict test. Benedict test positive. So all extra fructose is present in urine. It is not increasing blood. When it is not present in our blood, it will not going to affect our body. So no symptom would be there. So in essential fructosuria, patient is asymptomatic. Asymptomatic. Point out. Here I told you that galactokinase is deficient. Galactosemia means in blood. Semia means galactose increases in blood because high renal threshold. But here fructose urea means fructose increases in urine. Okay, not blood. So when it is not increase in blood, no symptom, patient is asymptomatic. Why it is called essential fructosuria? We say it is essential that fructose should go in urine to keep the patient asymptomatic. If all the fructose will be excreted in urine, patient would be asymptomatic. This is essential fructosuria. Benedict test would be positive. This is accidental finding. Sometimes patient is admitted for any other disorder, and when we did Benedict test, we found reducing sugar was present, and later on we found that patient was having essential fructosuria. Patient was asymptomatic due to this defect. Fructose 1 phosphate is acted upon by aldolase B. One question. In glycolysis, there was aldolase A. In fructose metabolism, this is aldolase B. How you will remember? Yes, fructose is a fruit sugar and fructose is a keto sugar. If you cut fruit, honey bee would come. B, honey bee. Yes, aldolase B. And you know, fructose is sweeter than glucose. And honey is having fructose in high concentration. That's why you call your girlfriend or boyfriend, hey honey. You don't say glue glue. Yes, why you are saying honey? Because you want to tell that you are sweeter than glucose. So we don't say glue glue. So fructose is sweeter than glucose. First point. And I told you that in glycolysis, aldolase A, in fructose metabolism, aldolase B. And if aldolase B is deficient, this is called hereditary fructose intolerance. In hereditary fructose intolerance, this step would not occur. When this step would not occur, fructose 1 phosphate will accumulate. And this fructose 1 phosphate, again, the same concept, inhibit glycogen phosphorylase. And when it will inhibit glycogen phosphorylase, all symptom, yes, all symptom would be just like classical galactosemia. So now I can conclude that Benedict test is positive in all these 4 disorders. Yes, minor type of galactosemia, essential fructosuria, hereditary fructose intolerance, classical galactosemia, all have Benedict test positive. In minor type of galactosemia, only and only cataract would be there. In essential fructosuria, patient would be asymptomatic. In classical galactosemia, oil drop cataract would be there, while hereditary fructose intolerance cataract would be absent. Differentiating point. In classical galactosemia, there would be relation with breastfeeding, milk. Because milk is having lactose. Lactose is made up of glucose and galactose. In hereditary fructose intolerance, there would be relation with the fruit juice. Fruit juice is having fructose. This classical galactosemia present early in life. Yes, first 2-3 weeks, patient will present. While hereditary fructose intolerance, typical presentation, you are sitting in OPD, parents will come saying that Dr. Saab, up to 4-6 months, child was absolutely okay. When we started giving him fruit juice, weaning, then these symptoms start. Yes, symptoms start around 4 to 6 months. When weaning starts, we start giving fruit juice. In classical galactosemia, question is asked, breastfeeding absolute contraindication. A question is asked, 3-week-old neonate who began vomiting 2 days after birth, usually within 30 minutes after breastfeeding, means relation with breastfeeding is there. Early period of life, yes. 3-week-old neonate, early presentation. Also abdominal distension, hepatomegaly, jaundice is there. Consulting doctor did urine dipstick test. One specific for glucose was negative. So in glycogen storage disease, the Benedict test would not be positive, usually. Okay. Second test specific for reducing sugar was positive. What is the diagnosis? So option A, hereditary fructose intolerance, it can't be because presentation is 3 week. Hereditary fructose intolerance usually present 4 to 6 months when we start weaning. Classical galactosemia, this is the answer. Essential fructosuria can't be answer. Patient is asymptomatic in essential fructosuria. The patient is having symptoms, so can't be answer. Von Gryke's disease, type 1 glycogen storage disease, you know the presentation. There is hepatomegaly, severe fasting hypoglycemia, renomegaly is there. There is lactic acidosis, hyperuricemia, increased triglyceride, increased cholesterol. So it's not von Gryke's disease. Now we come to sorbitol pathway. We found that glucose is converted to sorbitol by aldose reductase, and whenever you want reduction, you think about NADPH. So NADPH is used and sorbitol is produced. Now sorbitol is converted to fructose by sorbitol dehydrogenase, and you know dehydrogenase, hydrogen is removed, it is taken up by NAD to form NADH. So glucose can be converted to fructose, and you know fructose is rich in seminal fluid. So this sorbitol pathway occur in seminal vesicle as seminal fluid is rich in fructose, and it comes from sorbitol pathway. Sorbitol pathway. One question. Sorbitol, polyol pathway. Another name of sorbitol pathway is polyol pathway. We found that in diabetes, blood glucose is high, so more and more glucose is converted to sorbitol. This sorbitol accumulate in lens to produce snowflake cataract. Snowflake cataract due to accumulation of sorbitol. Now we come to glucose transporter. Glucose transporter may be sodium dependent or sodium independent. Sodium dependent glucose transporter do secondary active transport. Mnemonic S4 sodium, S4 secondary active transport. They are called SGLT. SGLT may be SGLT1, SGLT2. Sodium glucose transporter. So this is sodium and glucose symport. They are going together. We found that SGLT1 is present in intestine. Mnemonic intestine, I looks like 1. So intestine is having only one SGLT, that is SGLT1. And in diarrhea, we give ORS. Why ORS? Yes, ORS is absorbed via SGLT1 because sodium and glucose both go together by secondary active transport. Now, in kidney, there is both SGLT1 and SGLT2. Mnemonic I for intestine, intestine is having only SGLT1. Kidney are 2 in number, so it is having both SGLT1 and SGLT2. Concept, we know that if you absorb anything, that should not be wasted. Means if we take some glucose, it is absorbed by intestine. Now it is filtered by kidney. So nature wants that whatever absorption has occurred should not be wasted. That's why renal threshold of glucose is high. We want to reabsorb. So SGLT1 absorb in intestine and kidney reabsorb. So that's why nature gave 2 SGLT1 and 2. And we found that if there is defect in SGLT2, then it lead to renal glycosuria. Renal glycosuria. And this gave us idea that if a diabetic patient is there, in diabetic patient blood glucose is high and that is producing complication. If we inhibit this SGLT2 in diabetes, if we inhibit this SGLT2, then glucose will not be reabsorbed, will come in urine, so blood glucose will decrease. Oral hypoglycemic drug. So oral hypoglycemic drug, gliflozins, inhibit SGLT2. Mnemonic gluco flow हो जाने दो. Yes, glucose को flow हो जाने दो. That act by inhibiting SGLT2, and when glucose will come in urine, the side effect may be UTI, recurrent UTI may be there. Now, glucose transporter, sodium independent, GLUT or GLUT, whatever you pronounce, GLUT1, GLUT2, GLUT3, GLUT4, GLUT5. First of all, GLUT1. It is widely distributed, but we found that in brain and RBC, this is present in high concentration for basal glucose uptake. So question is asked, glucose transporter 1 is present in high concentration at brain and RBC. Also present in placenta, kidney, retina, colon, but questions are asked on these two. Yes. Glucose transporter 2, mnemonic is lip kiss. 2 lips, 2-person kiss. So L4 liver, L4 liver, I4 intestine, P4 pancreas, KISS, KI for kidney. And we found that these glucose transporter 2 are just like SBI bank worker. Normally they don't do work. Whenever workload is very high, then they do work. In the same way, glucose transporter 2, when blood glucose is normal, they will not work. When blood glucose is high, then they will do the function. Point it out. Means they have low affinity for glucose. High Km. Low affinity means they will work only when blood glucose is high. Low affinity, high Km. They are just like SBI worker, lip kiss. A question was asked that in intestine, this is luminal side, this is contraluminal side or serosal side. Question was asked that glucose transporter 2 in intestine is present at contraluminal side. Mnemonic is 2. 2 means दूसरा, दूसरी तरफ. Yes, intestine की दूसरी तरफ है ये glucose transporter 2. Now glucose transporter 3 present in neuron. Mnemonic is 3 has thrive. 3 has thrive. Thrive means high affinity for glucose. Neuron want glucose at any cost. That's why nature gave it glucose transporter 3, which is having high affinity. Means even if blood glucose is low, this neuron will catch and will utilize. High affinity. If high affinity, Km would be low. Yes. Km is inversely proportional to affinity. Now glucose transporter 4, this is really important. Many times question is asked. Yes, you will remember by heart. Heart is having 4 chambers. So it is having glucose transporter 4. Start mnemonic like this. Glucose transporter 4, heart 4 chamber, having glucose transporter 4. And this is girl is having heart. And when, so this Popeye the sailor muscle. Yes, dhak, dhak, dhak. After marriage, so much of samosa. Yes, adipose tissue. So 3, those are heart. skeletal muscle and adipose tissue have glucose transporter 4. Another mnemonic. Yes. Main function of insulin is to decrease blood glucose. This is really important statement. MAIN. If you count the letter of MAIN, you will find 1, 2, 3, 4 letters. Means glucose transporter 4. So MAIN is the mnemonic. 1, 2, 3, 4, glucose transporter 4. M for muscle. Muscle may be cardiac or skeletal. A for adipose tissue. So again repeat, main. M for muscle, may be cardiac or skeletal. A for adipose tissue. IN. IN means increases. IN means insulin. So now I complete the statement. Insulin increases concentration of glucose transporter 4 at cardiac muscle, skeletal muscle, and adipose tissue. Adipose tissue. Clear? Overnight fasting means in fasting insulin decreases. Insulin decreases. So glucose transporter 4 concentration will decrease at cardiac muscle, skeletal muscle, adipose tissue. So again I am repeating, this mnemonic is really important. Multiple time questions are asked. Main, yes, M for muscle, cardiac and skeletal. IN for insulin, IN for increase. Insulin increase glucose transporter 4 at cardiac muscle, skeletal muscle and adipose tissue. You may remember by this mnemonic or by this image. Now metabolic fuel, preferred metabolic fuel of different organs. Questions are asked in fed state, fasting and starvation. Liver is the main organ of metabolism and it utilizes, as we started discussion with carbohydrate. Yes, our first topic is carbohydrate we are discussing. After that, I will start lipid and after that, I will do protein. So in the same sequence, liver is utilizing in fat state glucose, then fasting state free fatty acid, fat, and then amino acid or free fatty acid, but not ketone bodies. Liver is the organ which can synthesize ketone body but can't utilize ketone body due to deficiency of enzyme thiophorase. For the time being, liver can't utilize ketone bodies. Brain. Our brain require only entertainment. Entertainment means glucose, but it also utilize ketone body in starvation. Yes, heart. दिल तो पागल है, दिल दीवाना है. Why दिल तो पागल है? Because even in fat state, when you are having sufficient amount of glucose, you are utilizing fatty acid even in fat state. तो कहेंगे दिल तो पागल है. Yes, so it utilizes fatty acid and in starvation it utilizes ketone bodies. So I summarize that most vital structure, brain, heart, and skeletal muscle utilize ketone body in starvation. Yes, brain is very vital, heart is very vital, and skeletal muscle, I say vital because even if you sleeping at that time, skeletal muscles are working. So you can remember like this, they utilize ketone body in starvation. So skeletal muscle utilize glucose in fat state, fatty acid in fasting, fatty acid in starvation, and ketone bodies also. So in this, if you don't remember all these things, I highlight that liver, glucose, fatty acid, then protein, amino acid. Brain, glucose, and ketone bodies. Most vital organ, ketone bodies. Ketone bodies means brain, heart, and skeletal muscle. This is important. Heart utilized fatty acid in fat state. And now RBC. RBC also require entertainment because it has no option. Yes, RBC, there is no mitochondria. Mature RBC has no mitochondria. So it utilizes only and only glucose because no mitochondria. As simple mnemonic, RBC is traveling via blood. Whenever it will feel hungry, it will take glucose. That's why nature said no need to give other option. Yes, you are always present in blood. So whenever you will feel hungry, you take and enjoy. So that's why RBC utilize only and only glucose. No mitochondria. Most vital organ, brain, heart, And skeletal muscle utilize ketone body in starvation multiple times. Question: myocardium normally utilize fatty acid. Lipid. Whenever you think about lipid, immediately fat word comes in your mind. Fat is made up of free fatty acid. So free fatty acid. Actually, this is not free. In our blood, fatty acid is attached with albumin. So question is asked that free fatty acid, they are not free in blood. They are attached with albumin. Albumin. The group name of all fatty acid is acyl. The common name of all fatty acid is acyl. If I say palmitic acid, stearic acid, they are saturated fatty acid, means they are having no double bond. Question is asked that how many carbon atoms are there in palmitic acid? 16 carbon atoms are there. You can easily remember, if you rotate P, it looks like 6. Just put 1. 16 carbon. As stearic acid, if I rotate this and put 1, 18 carbon. So palmitic acid, stearic acid, they are saturated fatty acid having 16 carbon in palmitic, 18 carbon in stearic acid. Unsaturated fatty acid. If there is double bond in fatty acid, then it is called unsaturated fatty acid. Unsaturated fatty acid further divided into monounsaturated fatty acid and polyunsaturated fatty acid. MUFA, monounsaturated fatty acid. Only one double bond is there. And MUFA is classified further into two types, omega-7 and omega-9. Examples are asked. Omega-7 fatty acid, example is palmitoleic acid. Palmitoleic acid. Palmitic acid was having 16 carbon, no double bond. Palmitoleic acid having 16 carbon and one double bond, MUFA, monounsaturated fatty acid. Omega-9, example mnemonic is ENO. ENO on acidity gone. E for elladic acid, elladic acid. N for 9, omega-9. O for oleic acid. So these are monounsaturated fatty acid, omega-7, omega-9, MUFA. Now we come to PUFA, polyunsaturated fatty acid. Example are omega-3 and omega-6. So omega-3 and omega-6 are PUFA. You must know the example of omega-3 first. Mnemonic is CAT. C-A-T. C for cervonic acid. A for alpha-linolenic acid. T for timnodonic acid. Cervonic acid is frequently asked because another name is DHA, and you have heard many times that formula milk is fortified with DHA. Why everybody is marketing like that our formula milk is fortified with DHA? Because we found that this DHA is found in high concentration in cerebral cortex, brain, and retina. So high concentration of DHA is found in brain and retina. And we found a correlation that retinitis pigmentosa patient blood DHA level was found to be low. It is not etiology, but it is a coincidence or correlation that retinitis pigmentosa patient have DHA level low. Nature is very wise. And that's why nature said that we will keep DHA in high concentration in breast milk. And exclusive breastfeeding up to 6 months. So constant source of DHA is breast milk. Breast milk. We found that this alpha-linolenic acid is second most essential fatty acid. Second most essential. Then timnodonic acid, name is sufficient. These are omega-3. We found that omega-3 are cardioprotective. They decreases the inflammation. So omega-3 advantage, they prevent cardiovascular disease or coronary artery disease. They decrease inflammation. So they decrease risk of degenerative diseases. So omega-3 is beneficial. Omega-6 fatty acid, mnemonic are garlic. 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 G for gamma linolenic acid, AR for arachidonic acid, LIC for linolic acid. This is most essential Fatty acid. Most essential fatty acid. Point it out. Most essential, I told you that this is linoleic acid. Second most essential, that is alpha linolenic acid. Now, all other PUFA are semi-essential. So most essential, two essential, other four are semi-essential. Now, arachidonic are frequently asked. Another name of arachidonic acid is eicosanoic tetraenoic acid. Eicosa means 20 carbon. Tetra means 4. En means double bond. 4 double bonds are there. They are asking question on eicosanoic tetraenoic acid because this eicosanoic tetraenoic acid or arachidonic acid is precursor of eicosanoids. Yes, these are compound which are termed as eicosanoids. Prostaglandin, prostacyclin, thromboxane, leukotriene, lipoxene, they are called eicosanoid because they are derived from eicosa tetranoic acid, arachidonic acid, R4. How many double bond? 4 double bond, frequently asked question. So these are PUFA, polyunsaturated fatty acid. Now we come to fatty acid synthesis. Before that, you must have an idea that whenever we take diet, in diet carbohydrate is there, and whatever carbohydrate we take, approximately 50% is sufficient to produce energy. So whatever carbohydrate we take, approximately 50% is used for energy production, while 50% is stored. Out of this 50%, 10% is stored in the form of glycogen, while 40% of carbohydrate is converted to triacylglycerol, that is fat. Means in our body, approximately 40% of carbohydrate we ingest, that is converted to fat. So carbohydrate can be converted to fat, but fat cannot be converted to carbohydrate. Question is asked, fat are not substrate for gluconeogenesis. So carbohydrate is converted to fat. That is the reason a concept is there that if you want to decrease weight, decrease carbohydrate in your diet. Previously, we used to decrease fat in our diet, but now we started saying, no. If you reduce carbohydrate, then weight can be reduced, and the concept is Atkins diet. Why? Because if you will take less carbohydrate, means extra carbohydrate will not be converted to fat. So if you want to decrease weight, decrease carbohydrate in your diet. That is Atkins diet. That is low calorie plus low carbohydrate diet. Total calorie must be low and carbohydrate must be low. Now we understand why I have discussed this carbohydrate here, because we know extra carbohydrate is converted to fat. How it occurs? Fatty acid synthesis. In fat state, when we take carbohydrate, means glucose is converted to pyruvate by glycolysis. This pyruvate enter mitochondria with the help of H import, proton import. Question is asked that pyruvate is not entering mitochondria alone. It will go with H import. Now in mitochondria, this pyruvate is converted to acetyl coenzyme by enzyme pyruvate dehydrogenase. Now this acetyl coenzyme enter Krebs cycle or TCA cycle to produce 10 ATP. Question is asked, one acetyl coenzyme enter Krebs cycle to produce, yes, 10 ATP. TCA cycle, 10 ATP. We found that when energy requirement of cell is fulfilled, then this extra acetyl coenzyme is converted to citrate, because